And it's sharing again the wrong screen. But basically, most important aspects I want to say, we're not anticipating a fire alarm. So in case we hear the alarm going off, we will all need to leave the building and follow the fire safety instructions. In case anyone wonders where the nearest toilets are, they are actually in this building, a bit further through there on the left. Riddy is the lady who's just running forwards and backwards here. She's absolutely helpful. So if you have any questions, she will also be able to help you and give you answers, as well as myself. As I just mentioned, the talks will be recorded here today. So we have the recording happening on Teams, and your voices will be recorded, as well as, I think, a view into this room. I'm exactly not sure how this looks yet. It's the first time I'm in this room, and we got here only probably about 25 minutes ago. We also have a photographer here to take a couple of photos. If anyone doesn't want to be on a photo, this is just for marketing purposes, but if anyone doesn't want to be on there, please let me know. And we make sure we take you out, or the photographer, let us well the photographer know, we make sure we don't include you. The idea is, of course, we have later a photo of all the speakers of today. Oops. And if anyone needs to take a little bit of a break, a breather, feel welcome to go outside in that space. It's called the Heritage Gallery, where we have our coffees and drinks and pastries, and just have a moment of retreat or relaxation, and then come back in again. So I would like to introduce now, well, the agenda. You can just a reminder of what is going on today. And I would like to keep this sort of on in the background in between, that we always know. But the first person to introduce the afternoon today will be our director of the ILD, Professor Sandhrian Patchay. Rosanna, would you like to come forward?
Thanks, Marianne. So do I just move the slides to...
Yeah. Okay. So just press it.
Thank you very much. Thanks, Marianne. So thanks, Marianne. As Marianne already introduced me, I'm the Associate Dean for Research and Knowledge Exchange in the Faculty of Education, Health and Human Sciences, and I'm also the Director of the Institute for Life Course Development. And I'm delighted to welcome you all to our event today, which is called Living with Chronic Illness as We Age, which is a research dissemination and knowledge exchange event. The event today takes place as a hybrid event, so I would like to welcome all our participants online, as well as in person on this beautiful Greenwich campus heritage site. The aim of this event is actually to showcase all the latest research that's happening in the Center for Chronic Illness and Aging, and to highlight strategies and recommendations to support daily living. We have invited fellow academics from across the UK. We have invited our NHS partners and members of community groups, as well as health group representatives. An outcome of this event will be a synthesis of the presentations and also a video. The event today is hosted by the British Society of Gerontology, as well as the Institute for Life Course Development. So I thought I'd tell you a little bit about the ILD. So I'll move on to the next slide. And the ILD was actually launched in 2019, so it's almost, we've been around for almost 4 years now, and it was launched as a new priority for the University of Greenwich to bring together interdisciplinary research that focuses on finding solutions to problems related to the inclusion of vulnerable populations in society. We take a life course approach, so we work from the cradle to the grave, and we have 7 key themes which are inspired by the university's strategic plan, as well as our core values, and of course the UN Sustainable Development Goals. So these 7 research and practice centers are the Center for Inequalities, the Center for Workforce Development, the Center for Chronic Illness and Aging, and of course this event today is hosted by the Center for Chronic Illness and Aging, the Center for Exercise, Activity and Rehabilitation, the Center for Thinking and Learning, the Center for Mental Health, and the Center for Vulnerable Children and Families. Now, an aging population means that people in the UK are living to older ages. So we're living longer than ever before, and this is a major achievement of modern healthcare. But although we have seen improvements in life expectancy, unfortunately, people are not living to old age in perfect health. And older age is characterized by the emergence of complex chronic conditions. Now, the ILD Center for Chronic Illness and Aging is working on transforming the world to be a better place to grow older. Today, we welcome researchers working across many different disciplines. So we have people working across healthy aging, musculoskeletal disorders, chronic pain, gait initiation, risk of falls, diabetes and nutrition, dysphagia, inflammatory bowel disease, cardiovascular disease, and many other chronic conditions. We really hope the event today will inspire you, and I wanted to thank the British Society of Gerontology for supporting the event, and a particular big thank you to Professor Lesley Dibley, the lead of the Center for Chronic Illness and Aging, as well as Marianne Markowski. Dr. Marianne Markowski is, of course, our ILD Research Fellow. And a big thank you as well to Ridi Kate for all the work that she's done in organizing this event. So I would now like to hand you back to Marianne and hope that you all enjoy the event. Thank you very, very much.
Oops. So I want to have a quick show of hands for those who can tell me that they know of the British Society of Gerontology. Ah, at least some, fantastic. And Melissa, is it because you just read the leaflet, or are you a member as well? Not a member. Okay, so the British Society for Gerontology, they actually provided me with some slides. I just need to get them up. Then content-wise, it's not a lot on there, but they have something which is called a small events grant, and we have applied for this, and that's how they sponsor us as well doing this event. But their interest, of course, is also to spread the word about the society. And I have actually someone here who knows the British Society of Gerontology very well. It's John Miles sitting over there. John, would you mind telling maybe, if you don't mind being put on the spot, a little bit about the society while I find the slides?
Okay. An unexpected gist. Thank you, Marianne. Yeah, gerontology is the study of the processes and dynamics of aging. It's a very wide-ranging field. It's not a discipline. And the society in Britain dates from the early 1970s. There's an architect involved in the original grouping that came together. I think very much dominated in the 20th century by social policy, sociologists. Increasingly in the 21st century, it has diversified. That partly reflects the way that higher education has developed in Britain. There was a period when several universities had centres for gerontology, predominantly focused around social gerontology, but at places like, say, King's in London, they're very, very close linked with medical and biological research as well. And I suppose now we've become predominantly a research-led association. So I'm just going to say a brief word without holding things up. The real crisis in gerontology in Britain, I told you it was a crisis, but the real crisis in gerontology now is about teaching across the board an aging population. The reality is the way it bears on our lives, the disparities that exist in the aging population, particularly at a time when there's a sort of cohort crisis affecting many people in the age group in this group, which understandably feels like a more pressing global dilemma. We have to look at these questions of intergenerational justice without demonising people like my age as kind of fat cats who somehow threw away the legacy of the 60s and left the rest of you to get on with the rubbish. So I think actually that political conflict has been problematic for gerontology because in a predominantly academic field, although we have a long history of engagement with all people's action groups, with service users, through participatory research, if you can't answer those big questions, then you're not really getting to grips with the problem. And I'm sitting here with arthritis, part of me who's going to film has irritable bowel syndrome. Living with chronic illness may not seem the most pressing of social justice issues, but I'm delighted as a member of the British Society of Gerontology that you brought out this theme today, and I'm looking forward to a very interesting afternoon. I was the original sort of administrator of the small events grant. These occasions when we're able to mix with people from other disciplines and people from local communities. Been a big feature of what the Society's tried to do in the last dozen years. So thank you for the opportunity.
I'm really glad you
Please do
stepped in.
join the BSG.
That's the quick message here, absolutely. And I just want to read out, sort of enhancing our understanding of later life. The British Society of Gerontology provides a multidisciplinary forum for researchers and other individuals interested in situations of older people and in how knowledge about aging and later life can be enhanced and improved. And the BSG is a registered charity. And what might be interesting for you, even if you don't join them straight away, but they have a really interesting blog. They also have videos called Aging Bites, and they have an annual conference coming up in July where I will be, have been accepted, and I also will be meeting John there. And you can, through the BSG network internationally, well, nationally first of all, but also internationally. So these are the perks I have picked out. There are more perks to it, but if you wanted to become a member, do let myself know, or you can even let John know, or have a bit more of a chat about it with me. So this was the beginning for, making sure that you know who our sponsors was, as well as, the ILD, who's our sponsor. And I would like now to hand over to Professor Sandhrian Patchay, who will be chairing the first 3 talks. And let's get the presentations up.
Thank you, Marianne. I thought I was not going to come to this lecture theatre again this year.
I just have to find the right one.
Because I've been teaching it here every week.
Oh my goodness, I didn't realize.
Do I use the mic?
Well, I have to create a shortcut. Create a shortcut here. So we have the first one is this one.
Okay.
Is it coming up? And then we need to. Okay, so the font doesn't. So, right.
Good, thanks. So our first speaker today is, well, let me introduce myself first, maybe.
Good idea.
Yes. So as Marianne said, I'm Sandhrian Patchay. I'm an associate professor in movement and cognition, and I'm based in the School of Human Sciences. So you'll see my presentation later, anyway, and you will know a little bit what I do for a living here. So I'm very honored and pleased to welcome Professor Lesley Dibley, who is Professor of Qualitative Nursing Research. And Lesley is also the center lead for the Center for Chronic Illness and Aging, of which I'm part. Very proud to be part of the center. And Lesley is an expert in inflammatory bowel disease, scoliosis and arthritis. And her presentation today is about public knowledge from research findings, learning from inflammatory bowel disease research. It's got to you, Lesley. So I've got some indicators.
Yeah,
Three,
that's
two,
the idea.
one.
There's too much to say. Okay. Thank you, Sandy. Hello, welcome everybody online. Lovely of you to come, and thank you so much. I am indeed Lesley Dibley, and just very quickly, I trained as a nurse, qualified in 1984, a long time ago, and right from the outset had an interest in chronic illnesses, and not particularly in the biology and the anatomy and physiology, although that's quite interesting, but really in the impact of chronic illness on life. I spent a while as a paediatric nurse, and children get chronic illnesses as well. In fact, there are several that can be diagnosed in childhood. And then, of course, you've got a lifetime of living with it. And that's really where my interest now lies in considering the impact of chronic illness across the lifespan, which means that by the time you get to being, I was at an IBD event recently, inflammatory bowel disease. Elderly IBD is described as IBD that's diagnosed at the age of 60, and that's me next week. So the idea of arriving at this age with a body that isn't as healthy as it can be because you've had 40 years of chronic illness is quite interesting. It adds an additional challenge. So I'm just going to have a little look at some of the work that I've done in inflammatory bowel disease over the years, and some of the key points that we can bring out of that and put into the public setting to hopefully be useful for people. So just going to have a quick look at what IBD is and what it isn't, because it often gets muddled up with IBS. They're not the same thing. We're going to have a quick look at that work that I've been doing. I've been in full-time research since 2008, so I've had plenty of time to get familiar with this topic, really. And then picking out some of the really relevant points for public knowledge exchange, what the public needs to know, really. Okay, so IBD, inflammatory bowel disease, is an immune-regulated group of gut conditions, includes Crohn's disease and ulcerative colitis. And these both cause inflammation in your intestines. They cause pain, loss of appetite, fatigue, loose stools and urgency and frequency, the need to hurry to the toilet many times, and emotional distress. The difference between the two in terms of Crohn's disease and ulcerative colitis is location. So Crohn's disease can occur anywhere between your mouth and the bottom end, and ulcerative colitis is in your colon or your large bowel only, all right, the very end bit of your bowel before you get to the exit. So theoretically, if you take the colon out because it's particularly horrible and you can't treat it anymore, you've cured the ulcerative colitis, but you've left somebody with no colon, and it has quite a big function in reabsorbing water into the body. These symptoms and their consequences all cause a degree of distress, depression and anxiety. There's a very well-known correlation between Crohn's disease and depression, and the rate of depression amongst the IBD population is significantly higher than in the general population. There's 500,000 people, that's 500,000 people in the UK with IBD. Now, when I started in IBD research in 2008, there were 300,000 people. Right, so it's nearly doubled in 15 years, and the rate, the prevalence and the incidence are increasing. Both of these conditions have a relapsing and remitting pattern, meaning that they have periods of time where they flare up and everything's really horrific, and then they calm down and everything's really quiet or quiescent. But when it's very active, it's described as being in flare, and you see this pattern of up and down, all right? And just imagine, if you can, trying to live with some of those symptoms that I've just described on an unpredictable basis like this, because that flare and remission pattern is not going to be regular, all right? And what the aim of treatment is to get you to this end point over here. She says, pointing with her not long enough finger, that it steadies it out, and you have everything quietened down, you know, and the person could think, yeah, okay, I can leave the house now because I know my innards are going to behave themselves. But what IBD is not is irritable bowel syndrome, right? And they're very, very different things. There are, you could argue, some similarities in some of the symptoms, but it's generally milder in IBS. But you can't diagnose IBS. There's no biological marker. You can't do a blood test. You can't take a what's the word I want, a biopsy or anything like that to prove that that's what the situation is. Whereas with IBD you can. So you can scope, you can look, you can do a test of the stool to get an inflammatory marker, and when it's very high rate it tells you there's inflammation there. But they're not the same, although there's some thinking now that there might be some overlap, particularly at early diagnosis stage, but it actually might contribute to a delayed diagnosis. But IBD is a chronic condition, and once it's diagnosed, it is there for life, right? You can't make this go away. It's like type 1 diabetes. You cannot make it go away. It's there and it stays. It is treatable with medical and surgical interventions, but it's not curable. So just imagine if you're diagnosed with this condition as a 17-year-old, all right, and then all the way through your life, that's the thing that you're dealing with. You're going to get to older age having had 40 years or so of really powerful medications, very likely chance you will have had some surgery as well. All right, and all of that stuff takes a toll on the body. So, sorry, there's quite a lot on here. Just going to have a quick whiz through some of the stuff that I've done. I was very, very fortunate to land a post working with Professor Christine Norton at King's in 2008, and this is the first piece of work we did and the first piece we published. Looking at continence in inflammatory bowel disease, because nobody in the clinical world was thinking about it. All of the people out there living with it were definitely thinking about it, all right? So we did this project and we came up with the first statistical evidence of how many people with IBD are struggling with bowel control, all right? And it's anywhere between 24 and 70%. Now, you might expect that when disease is in flare, but that's not okay if actually everything else is quiet and you've still got a problem. And in remission, at least 10% of people are still struggling with continence concerns. And we were the first people to flag that up. But we did, that was a mixed method study, so we also did some qualitative work, interviewing people about their experiences of living with this condition. And that was the first data to clearly evidence the enormous emotional and psychosocial impact that the condition has. It's stigmatizing, all right? All of us are supposed to be able to control our bowels. As adults, we're supposed to be able to do that. And if you can't guarantee that, and you can't guarantee to do that, you either are taking a risk of going out in public to do anything, or, and this is more likely, you're going to narrow down your world to being stuck at home because you dare not take the risk of having an accident in public, because it is the ultimate humiliation. Okay? And nobody was saying that or identifying it, but we did, so that was good. We then went on to do a bowel function questionnaire, which enabled people in clinic mostly, but also people going to their GP or wherever, to actually report how those symptoms, bowel symptoms, changed according to the activity or otherwise of their disease. And that would also, enable us to demonstrate what the variety of activity was like in terms of bowel symptoms, but also that for some people it's sustained all the time, and nobody was taking any notice of that clinically. That led me on to my PhD, which was all about stigma in inflammatory bowel disease and identifying the core issues that, because it was really interesting that some people are really stigmatized by it and other people really are not. You know, what is it that makes that happen or not happen, or how do people respond to that? And what are the important influences about control? Is not just physical control, it's about a sense of emotional control, feeling that you're in charge of things. Having social support and having mastery over your condition as well. Okay, this didn't look like this on my screen at home, I have to tell you, but there we go. We then did an intervention study. So we had all these people who were saying, yes, they've got problems with incontinence with IBD and we need to do something to try and help them. So we designed this randomized controlled trial, which failed miserably because we didn't recruit people, but we learned quite a lot about it on the way through. Looking at sort of straightforward everyday things that people can do without needing drugs or medicine or a visit to the GP or whatever else it is, to be able to get a better control over what's happening with bowels. We then went on and produced this IBD distress questionnaire. I'd done a lot of interviews to this point and we'd identified this theme of distress running through. So we did a secondary analysis of the data. We looked at data we already had for a second time. And we came up with this questionnaire that enables people to identify the things about their IBD that they find distressing. Right, and then that opens the door for their clinician, the IBD specialist nurse or the GP or the gastroenterologist or whoever it is, to say, okay, then let's see if we can do something about this thing that's causing you so much distress. And we've got 3 language translations of that so far. And I had another request recently for a German one. There you go, that's good. And then I did this study on living with a stoma for IBD. A lot of people who have this condition, and if you get repeated inflammatory episodes over a lot of period of time, you can do permanent damage to sections of the bowel to the point that the only thing you can do with it is whip that section out. And then people have to live with a stoma, which I'm assuming you all know what I mean by that. So the bowel is brought out onto the surface and the waste is collected in a little bag. And there was this enormous, I had this sense of a big difference between what people with IBD thought about that and what clinicians thought about it, because the clinicians are all going, clinically, you need stoma, and the patients are all going, you've got to be kidding, if I'm not going anywhere near it. So we did this study to try and find out what those differences were about. Really, really interesting. Clinical decision is based on clinical status, as you might expect. Patient's decision is about everything except clinical status. Patient's decision is about age, and that's not necessarily that they're too young, which is what the clinicians think, but it is more about time of life, activities of life, how it's going to impact or affect or whatever, than it is about clinical status. Clinical status is the last thing they're thinking about, okay? Interestingly, though, that when they finally get to having their surgery, which almost always they need, they all say they should have done it sooner because their quality of life is so much better. Because gone is the anxiety about the bowel control, gone is the pain, gone are the concerns. And I've interviewed people who've travelled the world with their stoma, obviously they can't go without it, gone kayaking, play rugby, all sorts of things. It doesn't had babies, all of this stuff. It doesn't stop, but there's a lot of fear about it because of the unknown, because nobody talks about this stuff. Okay. The top one there, sorry about the layout, kinship stigma research. This was about, I picked this up in my PhD, when family is stigmatizing, and that's horrible, okay? So if you've got something wrong with you in terms of a chronic condition, and the people that ought to be on your side are not on your side, that is much more devastating than if some random unknown person in the street makes some comment about you as they happen to walk past and you're never going to see them again. If you can't rely on your family, bearing in mind what I said earlier on about the importance of support in living with IBD and in any chronic illness, it's the same across the board. So that was really, really interesting. Devastating impact when they're stigmatized by their own close family members, and especially when that stigmatizer is their mother. Can talk about that too later if you wish. And then IBD Boost is currently going on, and all of the projects that I talked to you about, that Brett mentioned previously, have come together in this big online intervention study to develop this self-management program. It's got cognitive behavioural therapy components in there for helping people to self-manage as much of their conditions, because there's so much emotional influence, and anxiety and the stress of that can make symptoms worse. The IBD BME study looked at patients with Bangladeshi patients with IBD who didn't speak English. Now that was interesting, because we all speak English. We live in a Anglo-centric, we live in a society that has an Anglo-centric healthcare system. Right? So everything that it does and everything that it produces and all of its mechanisms are based around an acceptance or an assumption that patients speak English. Okay? So we did this study in an area of London where there's a very high Bangladeshi community, and it's a really small study because they're very difficult to recruit, and it was COVID era as well. But it highlighted some really interesting differences around the needs and perceptions of different communities. And so the message then is that that's what we have to think about. You can't assume that everything, because otherwise you put it out based on white people's perceptions, then you get care practices that are based on white people's perceptions and understanding. And we're currently doing the Presto study, which is building an outcome measure so that we can assess how people think about having a stoma and then how they adjust to it over a period of time. The idea being that if you can identify right at the beginning the people who are really going to struggle, then you can get the support mechanisms in early for them and improve their trajectory. So all of that leads me down to just pick out a handful of things that are relevant. So there's a cringe-worthy video on YouTube of me talking about inflammatory bowel disease, work I've done for Crohn's and Colitis UK, which is the largest patient charity supporting these people in the UK, about why I do that work. And I do that work because nobody else does that work. All right? I do the work around the poo and the stigma because nobody else does that work around the poo and the stigma. Of course, the findings that we have go out in clinical practice, which means that the nurses are then able to talk to the patients about based on the findings that we have produced and improve their care that way. I had a really interesting time on local radio recently. I went along with a colleague of mine who is a music director of a choir, an ex-global soprano. And we were talking about music and singing and well-being activities that are beneficial for everybody, but also particularly in chronic illness. And I think we're going to have to start going this way, okay, that we need to be looking at non-pharmacological ways of helping people to live well with their chronic illness, and actually prescribing somebody, you know, a membership of a choir or 15 Pilates sessions if they've got scoliosis or whatever it might be, would probably be much more helpful for them and better for the health service than throwing some pills at them. Of course, the university has open access policy now. What that means is that any of you can access any of the publications that we have that we've put in an open access setting whereas previously they'd be hiding behind a sort of an academic journal paywall kind of thing. Whereas now, because we're publishing open access, and that includes on our university repository, then you can find that work and get it for yourself and read all about it, as it were. Lots of the work that I've done is fed into information leaflets for Crohn's and Colitis UK. So that's literally reviewed the latest iteration of their Living with Bowel Incontinence in IBD that I helped them write in the first place. And we update that regularly on the basis of the work that myself and Chris Norton and Kings and others do. And then, of course, there's events like this where we come and talk to you about the work that we're doing and the different the different effects that they can have. So the way that I'm going with this, bang on time, I'm pleased to say, is to tell you what's coming next. So the next thing I'm planning, and we've got our fingers crossed, got a big bid into the Wellcome Foundation. And we're going to hopefully be looking at inflammatory bowel disease, idiopathic scoliosis, a skeletal disorder of the spine, and rheumatoid arthritis across the lifespan. All right, so that we are then able to say, if you're a teenager with these conditions, these are the things that matter to you and that are troublesome. If you're in your 20s to 30s, these are the things. It's going to change. Yeah. What bothers you when you're 40 isn't what bothered you when you were 20. And in reference to what you were saying earlier on about not writing us off once we get to 60, what I found by the time I've got to 60 is that I'm finally wise enough to know what I'm doing in this world that I didn't have when I was 30. So we've still got plenty to offer, however old we are. So I think that's that for me. Yes, I'm done. Thank you. Thank you. can't be avoided. It can't be avoided. Nobody knows what the cause is. There's a lot of work going on to try and identify. So we know that there are genetic markers that predispose in the same way that there are genetic markers that predispose people to type 1 diabetes and to cancer, right? But something has to trigger it. And what that is could be anything, could be different for one person than it is for somebody else. You know, I can remember looking after a teenager who was diagnosed with type 1 diabetes, and he'd had a bicycle accident, quite a nasty one, a couple of weeks or months before, kind of thing. And another kid, his parents had split up. And what you hear is IBD is that there's often an event, they're ill on holiday, or you know, somebody dies, or something happens that is enormously stressful. Now, there is no way on this earth that you could prove a direct correlation between, you know, to say that stress causes IBD. It certainly, once it's there, makes symptoms worse. Nobody knows. But there's also some thinking around environmental factors. You know, the diet that we're eating is different now than it was when I was growing up. Certainly, you know, we didn't have the only takeaway. I grew up in Norwich, in Norfolk. The only takeaway you could get was fish and chips. Right? That was it. And everybody cooked at home and all of that kind of stuff. And so what we're eating globally is different to how it was. Smoking makes it worse. Overuse of antibiotics makes it worse. Anything else I can think of off the top of my head? No. But there'll be other people who've done all of those things and they don't develop it. So there has to be a predisposition first. But there's no answer to what.
Any of your leaders cover better practices?
Sorry?
Any of your information cover better practices?
Well, yes. I mean, obviously not smoking. I mean, that's good for your health anyway, not to smoke. But there's, I think it's with Crohn's disease, it specifically makes it worse. But you can't say that it's causative. That's the thing. Okay. So not. Best you can do is to minimise exposure to the things that are believed to be influential. So don't take antibiotics unless you really, really need them, you know, and that's a message out everywhere, isn't it? You know, don't smoke, and if you are smoking, then stop smoking. And also think about what you're eating, because you would think it'd be really, really obvious that you're talking about an intestinal condition, then what you eat must make a difference. I don't know, they don't know, we don't know whether what you eat is influential in triggering it in the first place, but it certainly makes a difference to symptoms and how bowels behave once you've got it. Right? But you're dealing at the same time with the problems of poor nutrition because you're not absorbing things because it's all just shooting through too quickly, etc.
Is it genetics, or is it a lot of all these chemicals they're putting in food?
Well, who knows? Who knows? Who knows? I mean, like I said, there are genetic markers that show up more in people who have IBD than in those who don't. And because there's genetic markers, then it's going to pop up in families, and you'll hear people say, oh yeah, my aunt had a thing, or my great aunt Mary had a thing, or whatever it was. But it's not inherited in the way that something like cystic fibrosis is, where it's a defined inherited condition. So it's a tendency, a hereditary tendency, rather than genetically transmitted like cystic fibrosis. I'm not sure that answers you. I can't answer the question because nobody knows. That's the problem, you know. But it's a good point that you make, because what happens to a lot of people who have IBD is that others will say to them, well, why don't you just stop eating X? You know, perhaps if you ate better, if you changed your diet, as if it was as simple as that, which it isn't. And it's also changeable. On one day they might be fine with tomatoes, and another day they might not be, you know.
Go into a supermarket, there's a little corner that says natural foods. What's the rest of the food?
Yeah, exactly. But it's a good point, because you know there are many more preservatives and in foods now, because we've got used to being able to have anything any time of year. So things are imported and preserved to be able to last or whatever. Yeah. So good question. Thank you. Any others? Yes.
Do you find, because we're saying about the things that are impacting it, do you find that lower income families, for example, who can't afford the proper nutritious food, do you find that they kind of fall unfortunately to the more area of having these conditions?
It's an interesting question. I don't think that socioeconomic status is a predictor of whether you're going to get the condition or not, but it certainly will make a difference to your social capital and your financial capital to be able to deal with it. But then the thing anyway, regardless of your socioeconomic status, is likely to have an impact on your earning capacity. You know, and I remember interviewing a chap who had to retire early. And he literally couldn't get from his front door to the end of his front garden, which was about 20 meters, you know, because he needed the loo so often and he was always rushing in and out, and he'd had to retire, and he was aeronautics engineer or something like that. And he was completely distressed by this because it trapped his wife in a job that she didn't particularly enjoy because his illness pension wasn't enough to live on. So, you know, somebody who's in, you know, in a very poor social class might go, well, lucky you, you've got an illness pension kind of thing. It's all relative, isn't it? But it has its effect all the way across the board. You know, people don't take on promotion opportunities because they can't commit the stress and the work and all of that kind of stuff. But to go back to your question, if you have more social capital, then you can buy better foods, you can afford to work a little bit less perhaps so that you don't get so stressed, you know, you have more opportunities to manage those things a bit more easily, absolutely right. And that's the same across the board for any chronic condition. Yeah. Okay. All right. Thank you.
Well, thank you very much.
Thank you.
That's really good.
Excellent.
Right, I'd like to welcome Professor Omo Ojo, who is our next speaker and a very dear friend of mine. Omo is a professor of nutrition and diabetes, and he's also the practice lead for the Center for Chronic Illness and Aging and the Center for Exercise, Activity and Rehabilitation. Now, Omo is an expert in diabetes and nutrition, and his talk today is about the role of nutrition in managing people with type 2 diabetes. Over to you, Omo.
Thank you for the introduction. I'm just going to go straight to my presentation. Like Sandy said, my presentation is on the role of nutrition in managing people with type 2 diabetes. I'll just give you a brief definition of diabetes. Diabetes is a metabolic disease of multiple etiology. It's usually characterized by chronic hyperglycemia and results from disturbances of carbohydrate, fat, and protein metabolism. This is essentially due to defects in insulin secretion, insulin action, or a combination of both. So it is the dysfunction in the production of insulin and the resistance to its action that leads to the loss of glucose homeostasis. As you probably know, glucose homeostasis is the constancy of the internal environment and mechanism by which that constancy is maintained. So once there's a derangement, you then have chronic hyperglycemia, and all of the challenges we find in diabetes are as a result of the chronic hyperglycemia. In terms of the classification of diabetes, we could have fasting blood glucose. So when you're fasting, you fasted for 8 to 10 hours overnight, and your blood glucose is more than 7 millimoles per liter, then you can be classified as having diabetes. If you've had a meal after 2 hours, you know, you expect your blood glucose to rise, then it should come to close to near normal. Or if it's above 11.1 millimoles per liter, then you are classified as having diabetes as well. So if you also have an average, what you call glycated hemoglobin, that is an average glycemia over 8 to 12 weeks, and then your blood glucose is higher than 7% or 53 millimoles per mole, then you're also classified as having diabetes. So these are the ways you can be classified as diabetic. In terms of the prevalence, it's good to underscore the significance of diabetes. It's actually increasing across not just in developing countries, but also in developing economies. The both diagnosed and undiagnosed diabetes is estimated at about 463 million people. That was in 2019, and this is expected to rise to 578 million by 2030, and even 700 million by 2045. If you look at the graph here, you can see that it's increasing across the age groups. So as we move from 20 to 75 to 79, it's actually increasing across board. And if you look at in terms of both rural and urban settings, it's more in urban settings, clearly because of the differences in lifestyle compared to those in rural areas. And this is expected to even multiply by 2045. In terms of expenditure, because it's good to recognize how much is spent on this, let's look at the prevalence. You can see China and India, of course, because of their population, is expected, and Pakistan, United States. These are the 10 most countries where you have the highest number of patients or people with diabetes. And this is again expected to not change significantly by 2045. So in terms of expenditure, you can see that people from North America and the Caribbean, they appear to spend much more money on diabetes in terms of health expenditure compared to Southeast Asia, which appears to spend less. The symptoms of diabetes are actually, they do emanate from the chronic hyperglycemia. So you can have polyuria, which means you have increased volume of urination and increased frequency of urination. There's blurring of vision because of the changes in the shape of the lens. There's thirst because you are, and having a lot of increased frequency of urination. You also have weight loss because most of the glucose that should have been utilized for energy and stored as fat is lost in urine. In very severe cases, especially in type 1, you can have diabetic ketoacidosis and hypersmolar hyperglycemic state. So I'm not going to have time to discuss the details of this, but if you do ask, I'll be happy to explain as we proceed. So when we look at polyuria, you look at osmotic diuresis, because the handling of urine is very complicated when patients have chronic hyperglycemia or raised blood glucose. So when it's normal, you can see that the glomeruli is able to filter this, and if there are traces of glucose, these are quickly absorbed in the tubules. But in patients with type 2 diabetes or type 1, because of the high glucose loads, the reabsorption capacity is exceeded. So the body is not able to reabsorb all the nutrients, whether it's glucose or electrolytes. I'm looking at sodium, potassium, chloride, fluoride, and all of the electrolytes. So they are not reabsorbed. So all of these are flushed out in urine, and that is the problem. So in terms of the types of diabetes, there are three main types. There's type 1, where there's absolute cessation of insulin secretion. There's type 2, where there's a residual production of insulin and there's a resistance to its action. And then, of course, there's gestational diabetes, which occurs during the course of pregnancy because of the profound hormonal changes that take place during the course of pregnancy that can lead to insulin resistance and, of course, chronic hyperglycemia, and that what tends to resolve soon after birth. Now, coming to the etiology of type 2 diabetes, there are a whole range of factors. If we are overweight and obese, that can increase the risk of insulin resistance and, of course, chronic hyperglycemia, and then type 2 diabetes. Depending on our lifestyle, it depends on the kind of food we eat, whether they are mainly Western lifestyle or we're eating lots of fruits and veg, which can then enhance our nutritional profile. Genetic predisposition, just like Lesley said, if we are genetically predisposed to developing certain conditions, then we are at risk of developing that condition. And our gut microbiota, dysbiosis, So it is a complete change in the community of gut microbes because of the food we are eating that can also predispose us to developing type 2 diabetes. And age, as we can see from that slide, as we grow older, our capacity to produce insulin drops, and age is a factor. Ethnicity, it would appear that people from Black and ethnic minority groups are at greater risk of developing diabetes, type 2 diabetes, compared to Caucasians. Smoking, nicotine is a factor that contributes to insulin resistance, and it can promote chronic hyperglycemia and diabetes. Now, like I said, the kind of food we eat, like low intake of dietary fiber and the consumption of foods that are high in fat, which are common in Western lifestyle, have been reported to contribute to the depletion of certain bacteria taxa. And of course, that can then lead to changes in the diversity of the gut microbiome. So in terms of how this is the pancreas. So you can see this is the pancreas where insulin is secreted. You can see the pancreas has different cells within the islets of Langerhans. You have the beta cells, which produces insulin. What insulin does is to facilitate the entrance of glucose from the blood into the cell. And then you have glucagon, which is produced in the alpha cells. It counters the action of insulin. So when the blood glucose rises, insulin helps to push glucose into the cells to maintain the balance of glucose. Now, when the blood glucose drops, the body produces glucagon. It helps to break down glycogen to release glucose, and homeostasis is restored. So just to underscore the significance of insulin, mechanism of insulin action. So once we've just had a meal, our blood glucose rises. So what the body does is to produce enough insulin to deal with the rise in blood glucose. So once insulin gets to the cell surface, the cell membrane, insulin locks onto the insulin receptor at the cell membrane. So this then triggers biochemical reactions within the cell cytoplasm and leads to the translocation of glucose transport 4 from the cell cytoplasm to the cell membrane. So once that happens, because you have large molecules of glucose outside of the cell, you then have glucose molecules being facilitated by the glucose transporters from the cells, from the blood. So it moves straight into the cell cytoplasm. And once it gets to the cell cytoplasm, it's phosphorylated. Phosphorylation is the addition of phosphate to glucose. So it becomes glucose phosphate. And that then goes through the glycolytic pathway. So glycolysis at the end is the production of pyruvic acid. So during that process, ATP is produced, adenosine triphosphate. So that's the ready substrate that we utilize for energy. So now the glucose can be used for energy. Excess is stored as glycogen and excess is stored as fat. The problem with diabetes is that insulin in type 1 is clearly non-present, whereas in type 2 it's just residual, or there can be a resistance to its action. So all of these processes don't happen. So you then have no insulin or residual insulin, and then you have you have glucose in the blood, but not within the cell. What you have is what you call cellular starvation. So you then have chronic hyperglycemia in the blood, but not within the cell. So that's what happens in diabetes. This is what happens on normal physiology. But in diabetes, there's no insulin in type 1, or there's some just minute insulin in type 2, or there's a resistance to its action. When you're talking of resistance, you are looking at maybe a sudden change in the structure or the genetic material of the insulin receptor. So insulin cannot lock on very well to the receptor. So it cannot trigger glucose transport. So this glucose transport sits here, it can't move. Okay, and then glucose can't come into the cell. Glucose is just within the blood. And then you measure it, it's very high. So in terms of the classification of diabetes, you have acute complications, and then you have chronic complications. I'll just quickly mention this. I'm not going to go into details. With chronic complications, you can have microvascular complications like nephropathy, neuropathy, and retinopathy. These are diseases that affect the kidney. Okay, that's nephropathy. That affects the eye, will be neuropathy, and retinopathy. And then, of course, that affect the nerves, will be neuropathy. There are also cardiovascular issues, cerebrovascular disease, and peripheral vascular disease. That explains why it's essential that we intervene. So our interventions have been nutritional interventions. There are different forms. There are dietary interventions, there's exercise prescription. There are a whole range of interventions you can deploy. However, we focused in terms of our research, focused on nutritional interventions. That's what I'm going to quickly highlight now. So there's evidence that nutritional interventions are useful for managing people with type 2 diabetes. In this regard, what we have done, we've conducted a series of randomized control trials. We've also conducted meta-analysis to examine the effects of low carbohydrate diet in patients with type 2 diabetes. We've looked at low glycemic index diet in patients with type 2 diabetes. We've also looked at almonds in patients with type 2 diabetes. We've also looked at dietary fiber and prebiotics in patients with type 2 diabetes. Thank you. Yes. So in terms of low carbohydrate diet, what we did, I worked with colleagues in China. We carried out 2 randomized control trials in collaboration with research colleagues in China to evaluate the effect of low carbohydrate diets in patients with type 2 diabetes. So one author, for instance, found that low carbohydrate diet can improve blood glucose more than low fat diet in Chinese patients with type 2 diabetes. It can also regulate blood lipid, reduce body mass index, and decrease insulin dose in patients with type 2 diabetes. According to one, this study showed that HbA1c levels in low carbohydrate diet decreased significantly by 8.5% compared to that in low fat diets, which was 4%. So Ren in our study reported that low carbohydrate diet could exert a beneficial effect on depression and glycometabolism in patients with type 2 diabetes. It suggested that the role of LCD in improving depression in patients with type 2 diabetes may be associated with stimulating the growth of short-chain acid-producing bacteria and increasing short-chain acid-producing production and further maintaining GLP-1 secretion. That is the pathway that we thought low carbohydrate diet was using to promote glucose homeostasis. In terms of the role of low glycemic index, we conducted 2 randomized controlled trials in India, and carried out 2 meta-analyses to examine the role of low GI diet in patients with type 2 diabetes. And what we found was that long-term use of low GI diet of Karela cuisine has been found to promote weight loss, enhance insulin sensitivity, and reduce the risk of cardiovascular events. The second study also found that there was a significant reduction of truncal obesity and glycated hemoglobin in patients with type 2 diabetes on low GI diet. We also found in our meta-analysis, however, we found no significant difference between low GI diet and high GI diet in relation to total cholesterol, HDL, and LDL cholesterol. So we demonstrated that low GI diet is more effective in controlling glycated hemoglobin and fasting blood glucose compared with high GI diet. Okay, I'll just quickly summarize because of time constraints. So the other studies we did was looking at almonds. We carried out one ROCT in China and one meta-analysis to explore the role of animals in managing patients with type 2 diabetes. And we found that compared to the effect of peanuts and almonds in patients, when you incorporate it into LCD diet, it was effective. Almonds. And finally, we looked at dietary fiber. So we conducted 3 meta-analyses, including network meta-analysis, to assess the effects of dietary fiber and prebiotics in patients with type 2 diabetes. And what we found was that dietary fiber can significantly improve the relative abundance of bifidobacterium to short-chain fatty acids and glycated hemoglobin. So I'll just quickly conclude before you can ask more of your questions. In conclusion, this presentation has provided insight into the role of nutrition in managing patients with type 2 diabetes. Thank you for listening. Any question? If no question, thank you for listening again. I just saved my bow habit.
Just checking the chat.
Sorry?
No questions.
Okay, thank you so much.
So our next speaker in this series is Dharinee Hansjee, who is a senior lecturer in speech and language therapy. And she's also the program leader for the BSc Honours Speech and Language Therapy. Okay, wrong, please. Now, Dharinee is a very experienced speech and language therapist, and she's also an expert in dysphagia practice. And Dharinee is going to talk today about living well with eating, drinking, swallowing difficulties.
Marianne gets that presentation up. So I've been working in clinical practice for nearly 25 years before coming into education. And I have a special interest in eating, drinking, swallowing difficulties, which the medical term is referred to as dysphagia. And probably zooming in even more, the interest lies around older adults. So I'm going to keep the focus of the presentation today within that area. So with swallowing difficulties, the onset of swallowing difficulties gradually increases as we get older. And I think it's more around 60% prevalence in the older adult living in care facilities. And for something that just takes 1 second, so when we swallow some saliva now, it's taking less, maybe just a second. It's an incredibly complex sequence of movements involved. And within that 1 second, there's about 31 muscles involved, working really hard for us to be able to swallow. For the presentation to make sense today, and for you to really grasp the impact of swallowing and aging on the swallow process, I thought I'll just run through the 4 stages of swallowing. So the first one is the preparatory stage. So when we see food and when we smell food, we begin to salivate, and that's actually the first stage of the preparatory phase of swallowing. And then there's a lot that we don't really think about that happens automatically. So bringing the food or drink to our mouth, being able to seal our lips around the spoon and the cup to retrieve the bolus. To be able to keep that food and drink in the mouth, we need to have a good firm lip seal. And if it's a solid, then we need to be breaking up the food. Okay, we need to be chewing down. So all of that, all of those actions encapsulates the preparatory stage of swallowing. Then you have the oral phase, where it's just a really small movement of moving the food or fluid bolus from the front to the back of the mouth. Now, with the preparatory as well as the oral phase, you can probably describe what's going on. You can feel food and fluid in your mouth. You can talk about and tell us what's going on, and some of it we can see. Whereas once the food or fluid hits beyond or hits our soft palate, and if we're wondering where our soft palate is, so it's that fleshy part at the back of your mouth. So if you say ka, 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 your tongue is hitting against the soft palate. When food and drink actually passes beyond the soft palate, then we're entering the pharyngeal stage, and that's the throat. So that's the third phase of the swallow process. You wouldn't be able to talk about all the little subtle movements that are going on in the pharyngeal phase, but what you might notice and be aware of is if food or drink is sticking in the throat. You'd report and you'd say, I think there's something there. I feel like there's always that sensation of food or drink in my mouth after in my throat after I eat and drink. And then there's this little sphincter. So there's a sphincter that lies just here that separates the pharynx from the esophagus. The esophagus is a tube. It's like a food tube. It's what we would refer to as the food tube, because we would want food and drink to be going down the esophagus. So that is the final stage, the esophageal stage. Okay, so just what we need to think about with the aging process is thinking about the reduction in muscle mass, the reduction in connective tissue and elasticity, the salivary changes that we experience as we get older, the poor dentition. All of these factors contribute to increasing the duration of each of those stages of the swallow process. Okay, so adding to that, there's something called functional reserve. And functional reserve refers to the way in which our bodies cope with stresses like infection. So you think about how a younger person, how quickly they might recover from a chest infection, as opposed to perhaps an older adult. So in an older adult and the effects of aging, there's this reduced functional reserve that we've got to also keep in mind. Add on to that chronic disease like dementia, where that's going to bring a host of cognitive issues. And with that, there are a number of eating and drinking behaviors that also puts this person at high risk of choking. And I say that, or aspiration. I go back to that diagram. So in this last picture, you can see that there's the esophagus, the food tube, and there's your airway. So if your swallow mechanism is not working as effectively and muscles are weak, connective tissue is not as effective, or does not have that elasticity that it used to, then you're going to find that very easily food and drink can accumulate and there'll be residue and it can easily tip into the airway. So if you add on difficulty with being orientating themselves, so some individuals with cognitive difficulties would struggle to even know that it is mealtime. They might take time to actually initiate the meal process, so bringing the food to their mouth. Attending during the entire meal might be problematic, so they might fall off to sleep whilst they might have food in their mouth. The decision-making of chewing food and then thinking whether I've actually chewed down and swallowed enough to take a drink, or just repeatedly taking consecutive sips of fluid, but actually not really managing it as well. The sequencing of all of these processes that are involved in eating and drinking a meal can actually impact on the person's safety when eating and drinking. So that's why we see in the literature, if you go back to the literature, that one of the highest reasons for admissions into hospital with older adults with swallowing difficulties is aspiration pneumonia, because you've got you are competing with the difficulty with swallowing, and the structures involved with swallowing are not working as effectively. But then there's also the fact that there's all these cognitive behaviors. There is no linear relationship between dysphagia, swallowing difficulties, and aspiration, so that's not what I'm saying. What I am saying is that as we get older and we are living with a chronic disease like dementia, you become more dependent. You require assistance with eating and drinking. You require assistance with having your mouth cleaned. You need positioning. You need to be able to be propped up in a suitable position. And it's all of these factors that can contribute to aspiration pneumonia. So today it's about thinking about what you can do and what the team of people looking after you can do to maximize quality of life. And I thought I'd put some strategies together in the way of a framework of please. What can we be doing to be living well, maximizing quality of life as we get older when we're living with chronic disease? So the first one is being proactive in seeking help. So I worked with a group of medical colleagues, and what we did was we looked at carrying out a quality improvement project, and we looked at the number of quite a number of swallow screens that were available. There must have been about 30 swallow screens, and we took the common elements across all 30 and came up with a 4-question test. Okay, do you cough and choke when you eat and drink? Does it take longer to eat your meals than it used to? Have you changed the type of food that you eat? Does your voice change after eating and drinking? So if you respond to yes for any one of those questions, it would be advisable to seek help, to get a specialist assessment. And I would say that because we want to be able to identify dysphagia as early on as possible, because that will allow us to sit with you and plan and future plan and open up that conversation that is so needed on what are your wishes? What are your wishes in anticipation of deterioration of your swallowing? What would you choose to do? How would you choose to receive your nutrition? So that's what would lead us to what we are all as clinicians aiming to get to, is that personalized care. And there's always going to be risks. It's so much, life is more risk management than exclusion of risks. There's always going to be risks. And as clinicians, it's our responsibility to inform you of the risks. And if you do have dysphagia, you do have swallowing difficulties, you want to continue eating and drinking, these are the risks. If you actually want to bypass the eating and drinking orally, and you want to rather have a tube in, we need to inform you about the risks involved with having a tube in your stomach and receiving your nutrition via a tube. And this was really important for me when I was working in the clinical setting, and it took about 10 years to eventually get to the point of developing multi-professional guidance on decision-making for people eating and drinking with acknowledged risks. So we decided to call it that because we are getting right to the target of the issue at hand. We will be laying out there are eating and drinking, swallowing difficulties, there's dependency, dependency for activities for daily living, as well as mouth care, there's positioning problems, and all of that can lead to malnutrition, dehydration, aspiration. So we are having a really honest, open, transparent decision, and we are most importantly putting the person's wishes at the center of our care. Together with the theme of personalized care, as speech and language therapists, what we would do is modify diets and fluids, if required, as a compensatory strategy. But what I've really been trying to get out there is that we need to be moving away from that medicalized model, medical model, and treat the person rather than treating the condition. And in order to do that, we need cultural humility to be asking the questions. So what would you normally eat? Where would you normally be sitting when you have your meals? Where do you shop? So that the intervention and the plans that we're laying out are going to be relevant and important for that person. And they're not going to be binning it as soon as they walk out of the clinic or walk out of the hospital, because it's going to be really pertinent to them and they will be fully engaged with intervention. There was the fourth P is positioning and swallowing. And there was a lot of work by Al Gadir, the papers in the reference list in 2017, where he discusses the positioning and swallowing and the impact of positioning on your swallowing. This paper, Sakuma, that just actually looks at the different angles that a person might be in and the stresses placed on all the structures of swallowing. And you can even try it. If you just extend slightly, even to that angle, and try and swallow your saliva, it's that much harder. Yes. So what we need to be working towards is minimizing risks in this group. And so this is just a really simple, basic strategy of getting the position right. It might look like 90 degrees is optimum, but that might not be the case for every person. Actually, for some individuals, trying to keep and hold a 90-degree position during an entire meal would completely fatigue them because they'd just be exhausted and they might not get enough oral intake. So it's keeping that balance and looking at the person and trying to support the person in the best way possible. The fifth P is prescription of medication. So prescription of medication I can spend a few hours on because it's such a huge problem, that awareness of medication and what are we doing with medication in this population group. For people who are struggling to eat and drink food and drink, then what about the medication? And that's something we have to keep reminding speech and language therapists about as well. So with this, there's a paper that I've got down at the bottom of the slide where it's a write-up for the Nursing Times just about medication administration in older adults and an incident that resulted in choking. So I don't know whether this is going to play. It might not play. So it might not have loaded as a video. So it was actually a video of a barium, a video fluoroscopy, which is an X-ray image of the swallowing. It's a pill that's coated in barium. And you would see, if the video was playing, you will see the person really struggling to shift the pill from that valvular space. So that area is in the pharynx, and it's called the valvular space, and that person just could not shift that pill. And it was only when, after taking a drink of water and tucking their chin in, which opens the valvular space, that the pill was dislodged. But just really really honing in on the importance of medication. Okay, so then the last P, and I couldn't find a synonym for mouth care, so I just put down that began with P. So I put down pay attention to mouth care. Again, another session that we could spend several hours on because of the importance, but very basically, there's the buildup of bacterial pathogens in our mouths, and as we eat and drink, and if this person is dependent on having their mouth cleaned, then they need to, if they are dependent on having their mouth cleaned, and we are not providing that care, they can have every chance of aspirating on their saliva, and therefore there's a very high correlation with poor mouth care and the development of aspiration pneumonia. So last slide, a quote from Atul Gawande's book on Being Mortal, which is a brilliant book. The battle of being mortal is the battle to maintain the integrity of one's life. And what I'm really hoping today is that from the little nuggets that everyone is delivering, that we can see how best we can work together in ensuring that you maintain the integrity and the enjoyment of quality of life, because it is, there was that 1,000-bed initiative, 1,000 days initiative, and it's about saved bed days is the ultimate or the most important currency. Thank you so much. Any questions?
Can I just say, I work as an advanced clinical practitioner with GP research. Most of my patients are elderly, very frail, and this is one of the biggest problems that I'm presenting with. I've learned so much. I've written absolutely little notes, so thank you so much. And I guess I'm after picking your brains. So one of the big things that we do in general practice is holding patients while we wait for them to see specialists. So if a patient is presenting to me with difficulty swallowing, and it's going to be a 6-week wait until they actually see a speech and language therapist, is there a top tip you can give me out of all of those amazing tips? What is your top tip that I can give their family?
I want to say it's twofold, and I would say positioning and mouth care. Yeah.
I do a lot of hearing.
Good, because I don't think we do enough of that.
So the positioning, so just checking in and rechecking and trying different ways of
What might be most comfortable for them.
Dharinee, you focused on the physiology of the difficulties, the actual structures that make it difficult to swallow. What about anxiety? So once a person has got a problem, how much does their concern about having that problem actually make it worse? What do you do about that?
Yes, so I think that's absolutely right. There's going to be hesitancy, there's going to be nervousness, and we see that in the video fluoroscopy clinic because it's quite a clinical environment as well that creates that anxiety. And it's reassurance. It's reassurance having the support of somebody there. Also, just again, I know that this is the clinic situation, but we would normally bring the screen around and show them exactly what's happening. If you're at their bedside, or if you're sitting with them across the, on a table, I think it's just the reassurance that we can break this down a bit more, and let's put less on the spoon and let's take time. I think a lot of the anxiety as well with being fed or having somebody assist you with your eating and drinking is the challenge around the pace, shoveling in because we need to get to the next person that needs help.
So what if we're out with great grandma in the cafe having tea and scones? What's the best thing that we can do whilst we're with somebody as a family member to help them not have too much difficulty? And what's the best way that we can support them?
Well, I guess you'd need to have an idea of what they can manage, and if scones are going to be challenging,
I mean, quite complicated, aren't they?
Yes, they are. So you would need to think about how you can support them, and maybe just breaking it up cutting it up in smaller pieces might be a way forward. or considering and having a good look at the menu and seeing if there's something else that could help. But where you're maintaining dignity, but but there is some modification of the food. There wasn't the time for it, but there was a service user, Val, who was brilliant even with the medication, but she has head and neck cancer, and she talks about how the tiny little pills were the ones that used to trouble her the most because it would get stuck in the folds of her throat. And she had the cognitive ability to say to the GP, I actually need my medication in liquid form. But sometimes they would forget, and so she sourced a tablet grinder and was able to get this sorted herself. So just think about the vulnerable patients. But with Val, she was receiving her food and drink through, or receiving her nutrition via a PEG tube in the stomach. And she was somebody who was eating and drinking for pleasure. And she said that holding a glass of wine at a wedding made her feel part of the ceremony, and that eating and drinking is so much more than nutrition.
Yeah. It's a big part of how we socialise, isn't it? It's example we do. Yeah.
Thank you. I'm not going to keep you because I know it's break time.
Well, thanks very much. We are having a 10-minute break now.
Interesting stuff. Well, we've got to wait until you've got the see if we get the funding, but we're going to need a few people to join our participation.
We also gather all the speakers we need.
Yeah, please do. Oh, right, hang on. I'm just networking. I could possibly wear them. Gorgeous, gorgeous.
Sweet and beautiful.
I think we'll wait for one more person, right?
Yes.
Yes.
Just want to sit all like in the chairs. I think that'll look quite nice.
Yeah, okay.
But yes, we can get out.
Looks like a summit. Yeah. We've got the brightest minds in the building today.
I can sit in the middle.
Oh, that's very sexist.
Yeah, the men on one side and the women on
Women on one side.
Of course, mix it up. We don't want to be sexist.
Okay, Marianne, why don't you and Sam? There you go. There we go. Which one?
The ILD one.
It's the standing one there, isn't it?
Yeah. Shall we bring it here or?
Oh, should we have that as well?
Yeah,
you could do.
Why not?
Yeah, why not? Why not?
That explains a lot. Actually, I had one question. I think I'll take some pictures and I'll ask you about it. But it's, I should take some pictures. Yeah.
Is that about swallowing?
Yeah, I got quite, invested. Everyone was, doing the presentation. I was like, let me just start taking.
I learned lots about diabetes. I have a master's.
I thought that'd be heavier,
No, they don't weigh anything, do they?
Okay.
Excellent. Thank you so much.
So, we get back.
Is that good?
Yeah, it's pretty good. Hold on.
It's a bit of a gap. I know Lesley and Dharinee.
Everybody is so smart.
Should we look serious?
No, smile. It's already clinical enough. Just take a bunch real quick.
Yeah.
You guys can do a serious pose as well if you want.
Okay. There we go. Right. I need to drink.
Thank you. No worries. The question I had, Bill, was about all brush. So kind of when people do open up, their mouth, tons of quite largely yellow but vibrant. What does that usually signify?
Okay.
What?
Fair enough.
I didn't realise you said it already.
That's the way it is. That's the way it is.
And what if they just don't and just complain about it? Does that mean it's
You know, I
normal
think
thing?
it's
Have they got
like
used to it?
It's the same thing.
Or are they just not very-
So you, everything that you were saying also was like just.
Are you really an expert?
Yeah.
And is there something that you just like condensed
Twice a day, just.
Twice a day.
Everybody
Everybody says twice a day. I think a lot of us people. Thank you so much.
Yes. No, it's actually.
No. Just purely for comedy. My parents are very interested in the medical side. My dad is always looking for a doctor or something to cure whatever chronic illnesses he has. But it's just general interest. It is biology, but it's always nice to know. And obviously my mom did a lot. She actually worked in care, so
Okay, so she would come home with lots of stories.
lots of stories. And definitely, we did take care of both my paternal and maternal parents. So it's just kind of like, it's nice to know. My parents also get into their own age, so the more you know, the better you can kind of help it. So this is actually been quite enlightening. Thanks so much.
So do you work for the university or just?
And contractors. So they have like a people you reach out. They've got quite a lot of usually it's kind of very interesting. No way. Are you serious? I know it's hard to put it. I come from university.
said he would, but anyway, there we go, never mind. No, we don't know that we did. So, no loss. Yeah. Yes. No. Okay. They have a really small log. No, but it's useful to know that. Can you tell me? Yes. And then I'll get this. Ojo. O-M-O-O-J. And there was a bit more, just more of so almost a short version. No, that's right. It's just, it's really helpful. Sometimes you just want to think about it a little bit more and then see if there's any more thing.
Brilliant. You need to show me
Yeah, let's go.
after the,
Yeah.
me now.
Okay, perfect. Yes, then I'll ask her to share this.
I'm sure it's Kafui Adjaye-Gbewonyo. Yeah, Kafui Adjaye-Gbewonyo. I'll rush with mine. You know what you see when you're presenting the screen there, normally when I teach this,
What is this here?
when I present, I get this at the same time. How do you do that?
As in?
How do you show only this? Well, when I show my lectures, it shows this. The two.
So what we do is we just views.
Okay.
So if this is done, this is what is visible, and then it just swaps
Oh, I
the,
see.
yeah.
Oh, because the other screen is away.
Yeah. No, it's just not all. Sorry, so that's why this is the
But you see, when the other screen is on.
You can see the teams people as well. Maybe this.
Sure, on the other screen.
Yeah, and we can just, if we don't want to cast this on the main screen, we can leave it as well. We just need to change it to the display. And then make this screen as the main screen and not display this screen, and it's just for the presenter to view.
Yeah, yeah. No, that's good. Next time I'll go and switch this off.
Or maybe you can just change the display setting and just swap it and it makes it easy.
No, but the thing is that if that screen is on, then this is shown on the screen.
So in that case, we can just minimize this and reject anything else, or if you don't want anything to stop this. This is definitely useful.
How many nodes?
This is helpful. And is that
Okay. Sorry, you good to go?
Yeah, full of mine. I hope my patients, yeah, seem to be better.
Okay.
yes?
What else?
Yeah.
Got it all. Okay, folks, if everybody's happy, we'll resume for the second the second part. We might have one or two people wandering in, but that's absolutely fine. I get to take over chair duties for this second session, which is lovely, and it's my great pleasure to introduce you to the very entertaining Dr. Sandhrian Patchay, who's going to be talking to us. You've got to be entertaining now, I've laid it out for you. He's going to be talking to us about his work on gait initiation and falls risk in older people. Over to you, sir.
Thank you. Well, thanks very much for paying attention to some of the research that we are doing in gait initiation. So that's one of my main areas of research. And this is something I've been doing, I think, since I was an undergraduate. Carry on doing the same thing postgraduate. My doctoral studies, my thesis, my PhD thesis was mostly on gait initiation and anticipatory postural adjustment. Now, I'm going to explain what I mean by anticipatory postural adjustment as we go along. And I'll try to give you some insight into what we mean by that. So these are three things that are related, and I'm going to talk about them in a kind of holistic way so that we don't separate gait initiation, aging, risk of falls, etc. So I'll try to bring all this together in my presentation. But first, let me tell you a bit about some statistics. They can be very alarming. They are quite comforting at times. For instance, by 2045, nearly 25% of the UK population will be 65 years old or above. And that's statistics from recent statistics from ONS. But by 2050, 21% of the global population will be 60 years old or above. And aging, unfortunately, is associated with loads of issues, in particular loss of mobility, but also falls or risk of falls. And approximately 1 in 3 older adults living in the community who are aged 65 years or above experience 1 or more falls every single year. And that's quite alarming. And 50% of those who are aged 85 years old or above, they fall at least once a year. And we know that falls is one of the leading causes of mortality, unfortunately. Now, if you look at gender differences and also ethnicity differences, so we see that women are 58% more likely than men to suffer a fall, but a non-fatal fall injury. And when we look at ethnicity differences, white older women are 2.5 times more likely to die from falls compared to their black counterparts. So those statistics, of course, tell us a lot of things. There's a lot of scope to do work, to do research, to develop rehabilitation programs, and so on and so forth. Now, what are the consequences of falls? There are many of them, but I've chosen a few that will tell you how serious falls are and how important we need to consider them. Now, nearly 40% of falls among 65 plus years old require medical intervention and or hospitalization. Now, people who have fallen at least once in the past or in the previous 12 months, they will need medical attention. They go to see their GP 4 times more than any other patient. Now, falls, obviously, at that rate, cost the NHS and social care services a lot of money. It's about £2.3 billion per year, and that's a rough estimate. And falls amount to 1.5% of the total healthcare expenditure in European countries. So it's not only the NHS, but it's across Europe. And 6% of falls result in serious injuries, including accidental death. And I've said falls is a leading cause of mortality, but there are secondary causes that lead to mortality. For instance, there are psychological consequences that lead, which are one of the construct is fear of falling. Now, when people are afraid of falling, what happens? They become sedentary. And that sedentary behavior leads to a lot of things. For instance, it can lead to obesity, it can lead to all kinds of cardiovascular diseases, etc. And as you know, all these they just grow and grow and grow and make people become senile, and ultimately this leads to death. Now, there are several risk factors that are associated with falls, and we can categorize them as extrinsic hazards. There's all those hazards, all those environmental hazards. So there are easy problems to address. And we've got all those intrinsic factors that are physiological. So these are physiological changes that are normally associated with aging. So examples of extrinsic hazards are obstacles that you may find in your way, uneven surfaces, stairs, poor lighting, and so on and so forth. Now, all these can be addressed very easily. But the intrinsic factors, they are things like progressive neurological disorders, such as Parkinson's disease and other neurological degenerative diseases. Then we got what we call degeneration of sensory system. For instance, visual impairment, muscle weakness. All these can lead to postural disturbances. And obviously, there is impairment of gait initiation, and this is what I'm going to talk about today. And assessment of gait initiation is very important because it can enable clinicians, but researchers at the same time, to identify and diagnose disturbances in the locomotor system. That is the way we start walking and the way we carry on with our rhythmic locomotion. And this is very important because a good understanding of that may enable us to understand what can lead to falls, and we can pinpoint some predictors of falls. Now, what is gait initiation? This is something, as I've said, I've been working a lot, probably over 2 decades on that. It is, I like to say, it is the most important phase in human locomotion, because when you start walking, when you execute the first step, if you don't execute it properly, you are very likely to stumble and fall, or you are very likely not to generate a proper rhythmic walking or rhythmic locomotion. So that's why it is probably the most important phases of human locomotion. Then, gait initiation normally is a transition from what we call a bipedal posture. So when you start walking, before you start walking, you're standing on your 2 feet. That's a bipedal posture. And then you need to lift one foot and then execute the first step forward. Now, when you lift that foot, you are moving. So there's a transition from a bipedal stance to a monopedal support. And you can see, if you walk, if you try to execute that first step very, very slowly, you are probably going to experience some form of imbalance. See? So when you execute that first step, there is a lot of biomechanical stuff going on. For instance, the body is involved in relatively high accelerations, and it has to apply a very, very complex system and complicated system of muscular control and motor control. Now, muscular control are all those periphery muscles that needs, there's an interplay between all those peripheral muscles, but at the same time, there's a motor control that comes down from the brain. And it's not an easy stuff. Executing a first step is very, very easy, but when you start thinking about the whole process behind it, then you realize how complex and complicated it is. Now, there is, during gait initiation, a manifestation of ground reaction forces under both feet. And that's something that I have been pioneering in my work, in my doctoral works, etc. And I will show you an illustration of that manifestation of force variations in a minute. And there is also, at the same time, a related brain activity that goes on in the brain, in particular in the motor cortex, because this is where that motor output is going to be elicited in order to have an effect on the muscles. That is, those muscle effectors, they will enable us to lift our foot and to execute the first step. Now, all these, that is, these two things, that is, the manifestation of ground reaction forces and those related brain activity, is what we call anticipatory postural adjustments. Why? Because they occur prior to any movement. For instance, I will show you that manifestation of force in a minute. If I make the intention of walking, before I can walk, I am already manifesting that force variation. And it is a very, very simple thing that happens. I will demonstrate with an illustration in a minute. Now, unfortunately, the literature shows that most falls occur during that gait initiation phase. And a good understanding of gait initiation along life course is important to predict falls. And older adults may experience difficulty in maintaining balance during that transitional phase. And this is probably one of the reasons why falls occur in older adults. Now, I was talking about motor control of gait initiation earlier. Now, that motor control originates from the motor cortex. And this is a very simple illustration of what goes on from the motor cortex. Here, if we measure the activity here, and then if we measure the activity in the spinal cord and then in the muscles, we will see that there is what we call a descending pathway from the motor cortex, that is from the brain area, which generates that motor output, right to the muscles here. So that's a very, very simple illustration. But in reality, what happens is that there is activity of antagonistic muscles in the limb, especially in the lower limb during gait activity. And those antagonistic muscles are the gastrocnemius and soleus and the tibialis anterior. Now, in this illustration shows very, very clearly where those muscles are located. Now, the tibialis anterior, it is in the anterior part of the lower limb, and the gastrocnemius and soleus, they are at the back of that lower limb. So they are called antagonistic because when one is activated, the others are inhibited. And that's how it works. Because if they are both activated, then it will be very difficult for you to lift your foot. So inhibition of gastrocnemius and soleus activity in the stepping leg, that is the foot that is executing the first step, is followed by a bilateral tibialis anterior activity. So inhibition and activation, so that's why we call them antagonistic muscles. Now, the onset of the tibialis anterior activity ends with the toe off of the stepping foot. So if I start lifting my foot and I execute the first step, then when I lift my foot, then the tibialis anterior will stop. Now, there is motor control, that a motor program that controls that relationship between that inhibition and activation of those antagonistic muscles. And there is a distributed network in the brain. It's not that simple, that is the motor cortex does it. No, actually there is a network which is made up of the motor cortex, basal ganglia, cerebellum, thalamus, etc. And that's how it looks like. That's a basic signal flows that are involved in motor control of gait. So you can see how much information is being circulated just for you to execute that first step. So anticipatory postural adjustment, what that means, I've explained. So these are all the manifestations that occur before a movement can take place. And they are translated or they are reflected in vertical ground reaction forces. Now, the Newton's law of action-reaction tells us that for every action there is an equal and opposite reaction. And this is what we try to show. And an impairment in that vertical ground reaction forces can lead to difficulty in transitioning from a bipedal stance to a one-foot support. And older adults, they are less capable of weight shifting or taking a very rapid step in order to avoid falls. And consequently, they can lose their balance. So how do we measure that? We use two force platforms, which you can see on the floor here, 1 and 2. And the participants, they will put the 2 feet on those separate force platforms, and we measure the variation of forces with those 2 platforms. Now, the stepping foot, you can see a rise in the vertical ground reaction force, and there is a kind of mirror image, a perfect mirror image of that same force under the stance foot. So when we look at the difference between young non-fallers and fallers, we find a significant differences between the amplitude of those vertical ground reaction forces. And then what we can conclude here is that an impaired peak amplitude of vertical ground reaction forces could be a good predictor for risk of falls. And we tried to do the same thing with EEG, electroencephalography. We measured movement-related cortical potentials. And what we normally measured is the readiness potential, also called the Bereitschaft potential, which is one of the components of the movement-related cortical potentials. And what that shows us is that a slow decrease in that EEG amplitude that is measured over the motor cortex, the primary motor cortex, precedes the implementation of a motor task, that is the stepping forward of the body. Now, this starts around 1.5 to 1 second before, and the self-initiated gait is normally preceded by an increased activity in motor cortical areas. Now, there is no significant differences in readiness potential between the three groups that we measured, unfortunately, and this suggests that there are no differences in levels of preparation and execution in a simple non-volitional gait, that is with no objective whatsoever, between fallers and non-fallers. And therefore, we can argue that those MRCP results, they do not seem to suggest that fallers prepare gait initiation significantly differently to young and older adults who are non-fallers. So therefore, we can't really rely on brain activity to tell us that this could be a predictor. But we can't stop there. Although it might not be an efficient in predicting falls, this needs further investigation. This is what we're doing in my lab currently. Thank you for your attention. If you've got any questions?
Any questions, anybody?
Yes, yes.
Well, that's a lovely, vivid presentation. Thank you very much.
Thank you.
I've written down, of course, I don't know when I'm reading it now. Oh yes, older adults are less capable of weight shifting or taking emphatic steps before falls. Now that's, I fall all the time, and that's probably true for 30, 40, 50% of my falls. And I'm very conscious that most of my falls are also to do with distraction. So I fell coming up the steps before. I was foolishly doing two things at once, and I can't rely on my body to do automatically what it used to do. But the main thing I don't pick up from my self-investigation is the importance of gait initiation. I wouldn't say for me that it's this first step that's critical. It's not a comment on your research. It's just that I think it's probably something I should take away and think about. That I tend to fall when I'm in the thick of moving about, not when I'm starting off.
Yeah. No, but that's a good, I think that's a good observation. There are several things that can explain that. I mean, the first thing that comes to mind is you are probably not able to correct online if anything happens to you. For instance, if you lose rhythmicity while you're walking, you can't correct online. That's probably why you've got that kind of fascination and you tend to fall over. So it's a bit like if you are walking, I put an obstacle in your way and you have to stop. All the time you find an obstacle and then you have to correct offline because you can't correct online. That is, you can't jump over the obstacle. You can't adjust your gait in order to overcome that obstacle. That's one explanation that comes to my mind. Now, the second explanation is probably, as you said, distraction. Now, you say that when you are doing two things, that is, when you are dual tasking or multitasking, you tend to observe that this happens to you. Now, we've conducted some studies. So I had a PhD student who just finished, and they were looking at single tasking and dual tasking while walking. That is, he's starting to walk, holding a glass of water, for example, half full or empty, etc. So that's a dual tasking, or compared to a very simple gait initiation, that is a self-cued gait, self-initiated or self-cued. That is, you think that you need to stop walking, then you start walking. It's what we call volitional gait initiation. And what we found was that dual tasking seems to be a better predictor of falls than single tasking. That is, when people are doing more than one task at the same time, they tend to stumble, and if they are not, they don't pay attention to what they are doing, then they fall over. And this is something that we know with, for instance, walking and talking is something that is very, very difficult to do. And yet we do it because we've got a very good control, motor control of that. But when you look at, for instance, patients with Alzheimer's disease or dementia, this is something that is quasi impossible for them to do. That is, walking and talking, they will inevitably fall over. So there are, all these dual tasking that are very, very good predictors of falling. Now we can think about other reasons for that. But thanks very much. That's a very good observation. Yes.
Are you diversifying much with mindfulness, fibromyalgia? Just basically muscles just quit working.
Yes, we've done, well, we are working with pain, but we are not working with fibromyalgia. We work with neuromuscular pain, but it was not experimental. It was more observational. But now we are doing something that is a little bit more experimental, but we are looking to, I've got another of my PhD students who is looking at plantar fasciitis, this plantar pain, plantar heel pain, and looking at what happens in plantar pain that makes it difficult for people to walk, and is it and do people who suffer from plantar fasciitis likely to fall over? Now, what we are finding is, because we are scanning the plantar part of the foot, and what we are finding is that there is the structural properties of the plantar fascia is altered. That is, the physiology is changed, and this is very likely to cause all those problems. It's not necessarily the pain, it is what accompanies the pain, that is, that the structural properties, denature of the structural properties that lead to risk of falls in those patients. But yes, unfortunately, well, fibromyalgia, there's been a lot of psychological research using it as constructs, but we haven't done that. That's a very good suggestion. We'll look into that.
So the motor or the action is a problem. That's just the muscles just quit.
Yeah, I won't be able to answer that question, unfortunately.
One more question and then we'll need to move on, but go ahead, go ahead.
Do you have this issue? Is there any specific exercises that we recommend to help?
Yes, I'll give you my tricks. Because they do work with Parkinson's disease. For instance, Parkinson's disease, they've got what we call a freezing gait. When they start walking, their gait freezes. Now, there are some very small tricks that can enable them to overcome that freezing. For instance, if there is freezing, you can ask a Parkinson's disease patient to lift their foot, that is a high flexion of the hip. So lift their foot and then execute the first step. And then their locomotion becomes rhythmic almost immediately. And then you've got what we call a goose walk. They can walk with long steps like goose. And this helps as well to sort of liberate them from that freezing. Yes, there are some exercises that people can do in order to overcome that. And then obviously work their muscles, strengthen the muscles, because we know that as we grow older, there is what we call death of a type of cells called BEM cells in the motor regions. They are what we call pyramidal cells, they're in the form of pyramids. And those BEM cells, so they die at a faster rate than in younger adults. Unfortunately, they don't regenerate.
Okay.
I think someone had a question. Do you want to take the last one?
We need to move to the next presentation, but we've got another question and answer session at the end. So if you could hold on to that and I'll come back to you if that's okay. Yeah? Cool. Thank you.
Thank you.
Thank you, Sandy. Okay, in all the best conditions, we're running late. So I'm hoping, our next presenter is online because she couldn't be with us today, so I'm hoping, Kafui, that you're there. And really just get her sorted out with her presentation, which of course she needs to control from her end. Hi, Kafui. Here we are. Dr. Kafui Adjaye-Gbewonyo is going to, I hope, be talking to us about cardiovascular disease risk. Is that right?
Yes.
Can you say something so we can hear you?
Yes, can you hear me?
Can't hear you.
Okay, one second.
Yes, yes, we've got you.
Okay.
Excellent, lovely. The floor is yours, my dear. Off you go.
Okay, thank you very much. So good afternoon, everyone. So I will be talking today about cardiovascular disease risk in England among 40 to 80-year-olds. So in this presentation, I will be exploring trends between 1998 and 2017 in England, so from middle life around 40 years of age to later life. So the data I'll be presenting today is from a project that we call EXPOSE. So it stands for Explaining Population Trends in Cardiovascular Risk, a comparative analysis of health transitions in South Africa and England. And it's a project that I'm leading along with Dr. Anibali Kois from Stellenbosch University in South Africa. And it's funded by the UK Economic and Social Research Council. And we're also working with some colleagues at UCL as well. So just to give a bit of background, so cardiovascular diseases, short form CVD, they are conditions that affect the heart and the circulatory system. So this can include things like coronary heart disease as well as stroke. And cardiovascular diseases are among the leading causes of death globally. However, in recent decades here in England, as well as some other high-income countries, deaths due to CVD have actually fallen over time. Although in other countries, for example, many low and middle income countries, those deaths are still increasing. And so what we're trying to do with this project, the EXPOSE project, is to get a better understanding of what some of the factors are behind this. So what the project is doing is we're looking at trends at a population level and CVD risk here in England, as well as in South Africa, a middle income country. And we're trying to explain those trends. So to what extent do demographic characteristics, behavioral, social and environmental, and other health-related factors explain what we are seeing? So just to kind of give a bit of a framework for what's driving this work. So what we hypothesize, so cardiovascular risk, the trends that we see over time are influenced by a few different things. So one is what we know as epidemiological transition. And these are like traditional risk factors like population aging, right? We know as people age, they tend to have a higher risk for many chronic diseases, including cardiovascular disease, as well as people's lifestyles or healthy behaviors, right? Smoking, drinking, and things like that. Medical interventions as well, and economic advances. But then there's also other factors that maybe you might call non-traditional factors. These include things like social determinants of health, right? So people's economic situation, socioeconomic situation, as well as also some interactions with infectious diseases as well. And this is particularly the case in low and middle income countries where there's a higher burden of infectious disease. And then environmental factors. So things like, climate, right? So climate is changing. So how does that affect it? So these are some of the things we're looking at in this project. So we're again looking at two countries, and I'll focus on England for this presentation because we're here. And so we're using data from the Health Surveys for England, which is an annual survey that's conducted nationally here in England. And we're looking at the year, about a 20-year time span from 1998 to 2017. And those years are mostly just so we can compare with the other countries, South Africa, that we're looking at. So this is kind of a view of the data set that we have for England. So again, right now we're working with 17 of those surveys. There are about close to 170,000 individuals, those who are over 16 years of age in this data set. And we have a number of different variables, including sociodemographic variables, as well as health variables. So people's height and weight are measured, their blood pressure, their cholesterol, and many other things, whether they smoke or not. So how do we define people's risk for cardiovascular disease? So there's many different ways of doing this. A number of risk scores have been developed across the world. So you might be familiar with some of them, those of you who maybe work in clinical settings, like the Framingham risk score. And these risk scores, they're designed to predict people's chance of developing cardiovascular disease, right? So one of the risk scores we're using is developed by the World Health Organization, and the latest version is from 2019. And what it does is it takes characteristics about individuals to predict their risk or their chance of developing CVD. So either say a stroke, a heart attack, right? It could be a fatal one or non-fatal over the next 10 years. So the WHO risk score, they have it for different regions of the world. And there are two versions. There's one version that requires you to have laboratory measurements like people's total cholesterol. There's another version that doesn't require any lab measurements. So that's based on your age, your sex, your blood pressure, so the systolic blood pressure, whether you smoke or not, and then your body mass index, which is a measure of overweight and obesity. So it looks at your weight compared to your height. So I'm going to present some of what we've seen based on this non-laboratory risk score. And these are preliminary results. So we're still in the middle of doing analyses, but I'm going to show you some of the preliminary results that we found here in England by age group and looking at differences by sex, so between men and women. So I'll start with 40 to 49-year-olds. And so I'll try to explain these graphs here. Let me see if I can get a pointer. Let's see, here we go. I don't know if this shows on your end, but so what we see for men are here on the left side. And what we see in this younger age group, 40 to 49-year-olds, is that over time from 1998 to 2017, it seems to be a bit of fluctuation, but hasn't been a whole lot of change in their risk for developing cardiovascular disease in this age group. So in 1998, it was almost men in this age group, excuse me, 40 to 49, had almost a 4% chance of developing CVD in the next 10 years. By 2017, it was about a little bit over 3.9%, so not a whole lot of change, right? Women, on the other hand, in this age group, we've been seeing declines, right? So from 1998, and it's important to note that the risk for men and women is different. So you'll see that for men, they have more than twice the risk at this age group, about 4%. Women, it's about 1.6, 1.7%. However, what we've seen it for women in this age group is that here in England, their CVD risk has decreased pretty steadily over time in this age group. So when we looked at 50 to 59-year-olds, then we start seeing that there's consistent decreases for both men and women in this age group. Now, as you'll notice, again, as people age, the risk goes up. So for men in this age group in 1998, they had about a 7.8% risk of developing CVD. By 2017, it had dropped to about 7.2%. And for women, similarly, you see that their risk of developing CVD in this age group dropped from about 4% in 1998 to almost 3% by 2017. So you see that there's decreases. It's still in this age group, men have almost double the risk. Then when you get to the 60 to 69-year-old group, we see a decrease as well, which seems to have been steeper from 1998 to about 2008, and maybe not quite as steep after that for both the men and the women. But it's still, you see a substantial decrease. So men in this age group in 1998 had about a 14 or 15% risk of developing CVD. By 2017, that was down to about 13%. And for women, they had about 10% risk of developing CVD in 1998. But then by 2017, that was down below 8%. So you can see that there's substantial declines in this age group. And then finally, for the 70 to 79-year-old age group, we see the steepest declines. And of course, in this age group, they have the highest risk of developing CVD. So in 1998, men who were 70 to 79 in England had about a 25% chance of developing CVD over the next 10 years. By 2017, that had gone down about 3 percentage points to 22%. And so women, you see that their risk is also quite high at this age. It's getting closer to that of the men. So about almost 22% in 1998. But by 2017, that was down to about 17%. So that's quite a large decline. So then this is what we've been observing for across age groups for men and women here in England, right? So, but what are the main things that are driving, what are the main risk factors that are driving these trends that we're seeing? So we can look at some of the different components of the risk scores, right? Some of the different CVD risk factors to try to get a sense of that. So one of those is body mass index, or BMI, which I mentioned before as a way of measuring people's nutritional status. So people who have high body mass index tend to be overweight or obese. And so what we see here, I'll explain this graph. At the top, we have females. And then each column is an age group. So from 40 to 49 on the left to 70 to 79 on the right. And then the bottom is where we have the males. So what you see is that in every age group over time from 1998 to 2017, body mass index has been going up for people in England, right? So it's been going up across all age groups for both men and women, and maybe more steeply at the younger age groups. Right, so that means that that's not behind the decreases we're seeing in CVD, right? So, higher BMI, the higher your risk of CVD. But what we're seeing is that people's BMI is going up, but the risk of CVD has been going down. So that's not the main thing that's driving it. So one of the things that may be behind it is blood pressure, right? So what we've observed is that for all age groups, for both men and women, that blood pressures have been decreasing over time, over the past couple of decades, right? And so at younger age groups, people have slightly lower blood pressures. The decline isn't quite as steep, especially for the younger men. But as you get into the older age groups, and particularly for the women, you see that there's been a large decline in average blood pressure, systolic blood pressure, from nearly 150 in 1998 to almost 130 by 2017, right? So that's one of the factors that maybe explaining the declines in CVD risk here in England. And then another one is smoking, right? So that's another risk factor that's used to predict people's risk. And so thankfully, what we've been seeing over time is that smoking rates have dropped. And this is, again, in all age groups for both men and women, right? And so, if you take women, for example, in 1998, almost 30% of women who were age 40 to 49 were smoking. By 2017, that was less than 20%. And so you see similar declines for men, not quite as steep. And then you might notice as well that in general, smoking rates tend to be lower as people age, right? So these are some of the main risk factors that the trends that we're seeing. And so some of the things that might be explaining these. And what we're looking at in this project, as we complete the project, we're looking at some of the other factors that might be behind some of the trends, right? So things like medication use, right? Use of blood pressure medications, for example. We also want to explore a bit of, climate. So how temperatures, because temperature affects things like blood pressure, for example. So we're trying to look at some of the other factors, people's socioeconomic status as well. But these are just a few preliminary results that we've been seeing. So what does this mean? What can we conclude at this point? Again, the study's not over, but here are some basic conclusions. So we know that cardiovascular disease risk increases with age for both men and women in England. In most parts of the world, this is the case. And we also know that men in England tend to have a higher risk of CVD than women at all ages, right? And at younger ages, in 40 to 49, that's more than double the risk. Men have more than double the risk than women. As people age, that the relative gap decreases. Then also we know that the increased risk with age and the differences across gender are largely tied to blood pressure, right? So blood pressure increases as people go up. As people age, it goes up in that same direction. Also with BMI, right? Overweight and obesity. BMI tends to increase with age, except in among the oldest age groups, right? So those are explaining some of the risk in CVD as people age, as well as some of the differences by gender. Smoking, on the other hand, tends to decrease with age for both men and women. Right. And then in terms of the trends, right, what we're seeing is that in England, CVD risk decreased for both men and women in all age groups, except for in the youngest age group of men, so in the 40 to 49-year-olds, where it seems to be a bit more flat, a bit stable over time, right? So that's something to explore and kind of think about why that might be the case. And the declines in CVD risk that we're observing are happening in spite of the fact that people are becoming larger, right? People are becoming more overweight and becoming more obese, but then overall the declines in both the CVD risk and CVD mortality are still occurring in spite of that. So the risk factors that might explain that are mostly the decreases that we're seeing in people's blood pressures, and it's also with the smoking, the decreases that we've been seeing in smoking rates. So what we can imply from some of what we're seeing so far is that in order to continue this trend of decreasing cardiovascular risk over time, continued efforts to reduce smoking prevalence, right, especially starting at younger ages where smoking is higher, are important, because we've seen that that's one thing that may be driving the decreases in risk over time, and also efforts to continue to reduce people's blood pressure, right? And so this might take the form of, say, interventions in terms of nutrition, right? Salt, for example, there's some countries, South Africa, for example, that have implemented mandatory reductions in salt at processed foods, for example. So at a policy level, those could be some of the interventions. Also, in addition to that, one kind of area that needs more attention is weight gain, right? So we see that weights are going up, BMI is going up, people are becoming more overweight and obese, particularly as they age. And that's something that needs to be tackled to help to further reduce CVD risk, right? Because right now it's not moving in the right direction. And, here in the UK, the government released a new obesity strategy around in 2021, right, in response to the pandemic. So I think, thinking about more ways, more interventions, not just at an individual level, but at a societal level, a structural level, to help to reduce weight can also help to address cardiovascular risk here. And then finally, thinking about some of the differences across gender, interventions that specifically target men, right, who are at a higher risk, and starting also at younger ages, right, where there doesn't seem to be as much change over time in their risk. Those might help to address some of the gender disparities that we're seeing in CVD risk. So, that's what I have so far. If you would like more information about this project, we have a website, which is www.exposeproject.net, where we try to put some updates on the work that we're doing. And then we're also planning an event in September where we should have many more results and have gone more in depth with some of this work. So that's scheduled to take place here at the University of Greenwich. So if you're interested, please do get in touch with me, and maybe Marianne or Leslie can put you in touch if you're interested. So thank you very much. And yeah, if anyone has questions, I'm happy to answer those.
Any questions in the room? Go, Marianne.
Does vaping count as smoking?
Sorry, could you repeat that?
Does vaping count as smoking?
Does vaping count as smoking? So in this survey, Sorry, I think there's a bit of an echo. Yeah, in the survey, vaping wasn't really, especially in the early years, like, 1998, it wasn't really a question that was asked. So most of the smoking, they do ask about other types of, say, like cigars and things like that, other tobacco use, but predominantly what we've seen is that it's overwhelmingly still cigarette use, at least in the survey. So I think now maybe in more recent years, there might be a bit more attention to that, but it's mostly smoking in terms of cigarette use here. Yeah. So, but I think that's a great point because, as cigarette use has been going down, especially among younger people, there seems to be an uptick in vaping and, e-cigarettes and things like that. And so I think understanding and looking more at how that might affect CVD risk is something that needs more attention. Yeah. So thanks for bringing that up.
It was an issue that came up at the IBD study that I was at the weekend about whether, because we'd already talked about smoking as being a problem for people with IBD and was vaping therefore safe. And there's an interesting paper published in January of this year that indicates it doesn't have any effect on IBD symptoms, but the recommendation follows that of the World Health Organization is that it should be people should be cancelled out of it whereas possible because it still has health consequences across the board anyway, just as smoking does. So it might be slightly different, but they're still okay. Have we got any online questions? Do we know? No? Okay. Lovely. Thanks, Kafui.
Thank you.
Okay, so that brings us to our last presentation of the day, which is the lovely Marianne. And we've also far been talking to you about with focus on particular conditions and perhaps the relevance and influence of those and things that we can learn from those in life. And Marianne is going to take a slightly different stance, I think, and talk to us about how we can work with people like yourselves in generating research and knowledge exchange projects, and what are the sort of ways of doing that, and some of the processes involved. Yes, would that be fair? Yes, pretty good. Okay, so exactly. Over to you. Thank you.
So thank you. So I'm aware that we're also running a little bit behind today. So I will keep my talk as short as possible, so we can also take some questions from the overall day. And just want to let you know again, because we're recording the talks, we're planning to then give you a follow-up email with the sort of, well, ideally a highlight video of the talks, but if not, you get the full recording depending on how it all pans out. But you will have some follow-up communication from us, if that's all right with you. So, just briefly about me. I did my master's in England. I'm originally from Germany. You may detect it from the accent. I did my master's in '99, then I worked as a UX, which stands for User Experience Design in Industry. There I noticed that, with many of the commercial projects I worked on, they always had this sort of, 18 to 35, 18 to 50, 18 to 65. But after 65, as if people stopped buying stuff at Sainsbury's or whatever, they wouldn't be invited anymore for any of the usability tests. Usability is another word for UX, usability auditor. So when I did my PhD, I intended to work or look specifically at the group of older people. When I say now the group of older people, there is not the group of older people. Older people are highly diverse. Basically, it's very few things, apart from the age as a marker, there's very few things we can sort of generalize about older people, older adults. But I thought actually the other day when I spoke with Lesley that, with looking at the sort of sections of chronic illness, we may be able to group people again. And then you come quite quickly to the conclusion it's not only older people who are affected by certain conditions, but actually from a younger age, like as Lesley described earlier, scoliosis, idiopathic scoliosis, which starts age 13 and you have lived 40 years with that. So my PhD research was looking at older people, but I have moved to looking at more intergenerational combinations. So you will find that as well with what I'm going to tell you now. So 2016, I started working for this university and I'm still here. Hands up for anyone who knows about knowledge exchange. Hey, really had a hand up? We are here. We're doing knowledge exchange today. So I'll give you a definition which is from LSE. It's a two-way exchange between researchers and research users or end users of research to share ideas, research evidence, experiences and skills. It refers to any process through which academic ideas, insights are shared and external perspectives and experiences brought into academia. So I'm actually really excited about knowledge exchange because knowledge exchange opens doors, I think. I guess we have done it already before, but now it has a label. So we have research and we have knowledge exchange. Research, as you're probably familiar, involves all kinds of processes which we have to obey, whereas knowledge exchange we can create in a much more friendlier, engaging way. As we did today, invite you to come over. We have some pastries, coffees, and hopefully chat afterwards as well. Just checking if I've missed anything. We all know when we start researching something, we start somewhere and we find something out and there's more to find out and it goes in circles. Effectively, you never get the answer. You only get more and more questions to look at more and more areas. So in the way of how we produce knowledge, which is what we do in academia and the idea, and obviously what the ILD wants to do as well, it wants to do very much applied research, working with people to solve problems with you, to address societal challenges with you. So we need to involve people like yourself, service users, service providers, clinicians, in this quest of developing the knowledge. Like, you know, when Sandy does his experiments or when Lesley does her interviews. When we start with a project, we obviously have the beginning of the idea, you know, how we start this project. And that's the point which is really important to involve service users or the people who have the experience and the knowledge of it. Then obviously when you do the research project, that's the time when you either work with the participants, and it depends on your research paradigm of how you work, whether you observe, whether you involve them as active agents, or use them as a stakeholder advisor. When I say them, I mean now research participants with the lived experience or what it is about. And then we have the dissemination activities, and that's again the area where you give the knowledge from academia to the others, to the participants, to the recipients of this. So I call this at the moment, you know, beginning of research, ongoing sense checking, and dialogue. These are not set terms. I'm just giving this as an example. So in those, you have at the beginning sort of discovery activities, you know, there are different forms of activity, discovery activities. I quite like the idea of co-creation, co-design, where you get together and you do a big brainstorm. So I personally like a lot of hands-on and arts-influenced methods. But it could be as well a straightforward, just a meeting and a good chat. It can also be a form of collaborations, or it could be a document that has been sent to you and you review and you give your feedback. That's where knowledge exchange activities can already take place. The ongoing sense checking is basically when you're involved in the research activities in whatever format the research or the research design had been thinking of. Sometimes I've done this a couple of projects where I involved the participant as a co-researcher. So there was, for example, one I worked with Lewisham Council, and we were looking at getting the criteria for the age-friendly communities badge ready. So I had worked with a group of older residents who then held discussion groups with residents, because they knew the residents and they had a different approach to the residents, and it felt very different to how, when I carry out research, because I come from university background. Obviously, stakeholder engagement and sense checking, again, by monitoring the research process. And at the end, we always, what we call in research dissemination activities, you may call it an information evening or another form of getting together and learning about information. It doesn't need to be always in person. It can be as well other formats such as video or a blog, or maybe something which has been created like a website or resource, and that's shared with you. And when we do this, it's helpful to get the feedback from you, because it helps us to understand, when I say us, in this case, the researcher, the academic community, how we need to prepare the information to make it more accessible, applicable, and it can actually be used. The last one, improved states, comes from my sort of background, because I'm quite of a design research perspective there. In design research, you change existing situation into preferred ones, into preferred states. So improved states, preferred states, obviously we all work together to improve things. We don't do, we don't work together to make things worse. At least that's not the intention. So, what are the challenges of involving people in research? And especially involving older people or people, vulnerable people, people from specific groups. Can I just see if anyone hands up who has taken part in research? Who was actually, okay, Rebecca, you've taken part as well? I know John has, at least with me. Has any of you actually taken part in research? Yeah. Because it's always quite interesting to see the other side of the coin, So working with, for me, my main experience is older people, older adults, but as well intergenerational activities. It is quite hard to find a representative sample, and I think quite a few, or at least I know of Lesley, she struggled with finding participants that had, IBD or scoliosis. But this, of course, depends again on from which research paradigm you come from. So if you come from an area where you want to produce research which is statistically significant, you have to have a significant number of participants. If you do more qualitative research, you can get away with smaller numbers of participants. But still, it's not always easy to reach them. It's also difficult to obtain precise and comprehensive information from the person, because sometimes, when you're older, you have dysphagia, you may have speaking trouble, it's difficult to understand the person, and so, or it may be too challenging, too fatiguing, too exhausting for them to take part. So this means for me as a researcher, I need to be prepared, I need to put more resources in, I need to put more time in, I need to think of more techniques of how to involve the participant. And I may need a specialist advice, tips, or protocols. I, for example, remember once when I guided a speaker who had a vision impairment, officially blind, actually registered blind. For this, I needed to know how to bring the person over to the room, and I didn't know this. I didn't know that you had to go from a specific site. Luckily, that person taught me straight away, and it was all straightforward. But these are things you need to pick up or learn and be prepared for. Ethical procedures, they can be, ethics are very important, but they can be sometimes a hindrance because, you need to give a form explaining the full study, what you expect, and a lot of reading, making sure the person understands it, and then having to sign it. It can sometimes cause a bit of a barrier for people to want to take part because it gets too much. And I don't know if anyone found this as well, that sometimes when you speak with someone you know, when they're in their 80s or older, and you ask them a question, and actually what you get as an answer is something quite different from what you ask for. So you have to keep them on track. You have to, you know, prompt the right way, and it means basically you just have to bring more time along and develop a good feeling on how to communicate and how to pose the question, but not just rely on the words. Rely as well on what you see. So I'm going to do a quick whistle stop of some pictures of research I was involved in. Here, left-hand side, you actually see me highly pregnant there. This is a storytelling workshop, which I very much enjoyed carrying out. Our ability to speak remains till, you know, we're quite in our, you know, later faculties. So we are able to speak, tell stories, and as you can see, have a two young men mixed in there as well. So that gave a nice little discussion. Here I did a design research intervention. This is my PhD. I created something which I called the Teletalker. It was a kiosk. And what I did here is I placed this in semi-public spaces, and the people who tried it out came there. But for me, the way how to collect the data was by just being there and communicating, because getting someone to sign an ethics form beforehand and so on, it wasn't possible, because that was taking away the time. So what I did is I informed everybody. I got, of course, ethics approval, and then I spoke with them, and I had a camera person with me, and they did a little video afterwards. Here again, this is the same big brown box but put on wheels, and I designed this for a care home. So I had experience of doing research with people who have dementia and also are not mobile. So again, lots of challenges. One of the challenges when I was here, I thought, like, okay, I'll bring some forms along and they can fill them in afterwards when they have tried it out. I didn't realize how difficult it was them to just fill a form because they needed their classes. I had a trouble or just didn't want to write. So scrap the form bit when you're in places with very vulnerable older people, but you know, be open for having conversations. This was a VR installation on a motion chair, which was fantastic. It's really, really amazing, you know, responses to it. But there you had to have at least about half an hour lead up of talking them through of what is going on. And you had to do a risk assessment, whether they had a pacemaker and other kinds of things. So it wasn't as straightforward, even though we like the idea of VR and new technologies, it wasn't a straightforward setup there. This is a project recently which I did, which was a knowledge exchange project. Very enjoyable. It was a somatic co-creation, so we did it based on movement, and with the movement we combined other activities, which was very empowering for everybody who took part. And there's a little video which I can only encourage you to watch. I'm not going to do this today. I thought first of showing it today, but it's unfortunately not enough time for that. And you know, and I took part as sort of a participant, and I have to admit it was very, very transformative, because it really brought home how important it is to let the body talk as well, not just your mouth and your, you know, the written word, but actually collect information from people from more sources than others. So this was another project. So key takeaways for today, for anyone who is here also potentially a service user and would like to be involved in research, I just want to say it. You know, it's really important that you give your personal experience. It's, you know, to feedback. Tell us what you experience. Have a look at your GP services or pharmacy, any kind of notices if you can get involved with this. Have a look at the HSCI, which is the Health and Social Care Northern Ireland website, but I put the link here. This is a really good explanation of how they involve you. They call the names not involvement, participation, engagement. Participation is the actual participation in research. And as I've written here down there. So you will be, I can send you as well those links. Have a look at those. And if you're a service provider, which I think we have a couple of people here who represent as well service provider, I can only say be really open-minded of how we involve service users, and you know, you make use of knowledge exchange activities, because it takes away this formal process and becomes a bit more of an informal way of interacting with service users. And when I say consider new forms of involvement, as I just said, for example, dance or other forms of expression, creation, making, and the other big message I would say, you know, get to know your service user and then prepare. It all takes time, but getting to know and preparing is really important. So thank you very much.
Okay, thank you, Marianne. I think it's really important for us to appreciate that. I mean, I know I use people with experience in all of the research that I do, but it's also really important to have your input before you get started on the project. You know, so I might be sitting in my office and come up with what I think is a brilliant idea. And before I get very excited by it, don't go away because there'll be a question I expect in a minute. You know, it's really useful to take it out to people to whom it might be relevant and say, what do you think of this idea? And what do you think might be the issues and the problems, and how should we go about it? So quite right, knowledge exchange activities all the way through with people with experiences relevant to a particular project that can help guide and inform the way that project goes. Right, any questions specifically for Marianne from that? No? Any questions online? Right, okay. So let's just open it generally for questions. So I'm going to come back to you because you've been very patient and you had a question for Sandy.
The gates analysis is really interesting. Was there any work or research around initiating a gait in a straight line and initiating a gait to rotate or to turn? And what the differences might be?
While walking a straight line, that's what we normally do.
Yeah.
We don't want to start walking. For the simple reason that we have to follow the type of treatment that we have. For instance, my other walking, I can't ask people to walk in that direction, that walk, on the walk. So that's one thing. Now, it's all about intention. If you make an intention to walk and then turn around on that. So what is more important is not the way you initiate the gait, is the intention that you're making. So that's why I always refer to the importance of anticipatory postural adjustment. Now, this is more to do about the intention and then the manifestation of forces and the measurement of brain activity. Now, I talk about readiness potential. Now, readiness potential is something that happens a long time before the movement occurs. So, for instance, if you make an intention, you get, there are two things. You can stop what we call making a prior intention of doing something. For instance, if you want to stab someone, if you make an intention to stab someone, you can stop that intention. But once it is being executed, you can't stop it. It's execution of intention and making that intention. So if you make an intention to walk in a straight line, you're going to measure the same kind of anticipatory postural adjustment. Even if you make an intention of going to a target and then turn around and come back, it's going to be the same. And I was talking about that PhD, which has been completed now, about looking at the difference between dual tasking and single tasking. And one of the protocol was to go towards a table, holding a glass of water, go towards the table, put the glass there, and then come back. And there was no difference whatsoever in terms of manifestation of those variations. So it's not really about measuring the force, it's about intention. And that's something that we don't quite understand, because intention will be reflected in brain activity, but not in the manifestation of external forces. But yeah, that's quite a wide program. And we've got the data, we're looking into it, but I don't know, we need to know how we approach the data.
Just following on from that, I'm not sure, I'm not sure if this is what you meant, but I can think of countless patient interactions where the elderly person is walking towards the chair So the intention is to walk towards the chair. When they get to the chair, the easiest way is to sit down like this. Yeah, you can visualize it. And so perhaps that's what you mean when you say, yeah, you're going in a different direction from.
I was thinking about that first step initiation, which is around the balance. And some people, or most people, will initiate that first step to balance with the intention of going forward straight.
Yeah.
And some people that we work with will do the first step initiation with the intention of not going straight, of multitasking with
A turn.
a rotation as well. And it's all in that first step. And I just thought they're adding more complication on a potentially cognitively complicated task already. So
And it ties back in. It ties back in with what you were saying about your higher risk of falling when you're distracted because you're doing more than one thing at the same time. You know, if all you're doing is walking, you're probably okay. But when you're distracted with something else, so that suggests that when the clients you're talking about are trying to multitask it, you know, get up and turn.
On the very first
Step, yes, yeah.
Yeah.
Whereas if that what you're suggesting, if they got up and took the first step and then they're up,
Yeah.
and then they make the turn, they're probably okay. But trying to do both at the same time,
Yeah.
it's just maybe an important thing to look at. So.
Well, no, but I'll tell you something. It's quite interesting, but now you make me think about it. We're working on a protocol, but we need to design the walkway. You know, elephants, when they walk, it's easy for them to walk in a curved direction rather than walking straight. You know, you see that when you go to India, all those forts and all that, their entrance is never straight. It's always a turn. And I've always asked myself, why is that? And then a guide once told me that, you know why? Because of elephants. They can't walk straight because of the ramp. So it's easy for them to walk sideways. Now, it looks like...
Sorry, why, Sandy? We didn't catch why.
No, why?
Why it's easy, why elephants walk on a curve.
But this is what we don't understand, and that's what we want to test with human beings. Is it easier for people who've got walking difficulties, especially when they've got impairment of initiation, is it easier for them not to start walking in a straight line, but to start walking in a curve? And instead, if they're going there, instead of facing there, if they face somewhere here, and then they go
They end
there.
up over there.
So is it going to be easier for them? So that's a bit of the analogy of how elephants walk. But we're not trying to build kind of walk, but we're not there yet.
Interesting.
Come back in here, because it occurred to me after I made my point, I'm forward so much recently, which is part because I'm very inhibited by having extremely arthritic. So that I would demonstrate.
Okay.
Stand up now. I feel awful. Yeah. So the first thing I now do is to slowly fill myself.
Yeah.
And start breathing.
Yeah.
And then I begin to move. Perhaps I've got that pain to me, so that's further inhibiting. Now, what strikes me about that is what a socially cumbersome and awkward thing it is to do.
Yeah.
But I suspect it's an approach that I would stick with and that I might disseminate through the peer learning initiative.
Yeah.
Marianne.
Yeah, but it's you see it, don't you? Lots of people do that for whatever reason. They have a difficulty with movement of some sort, or they get very stiff when they're sat for a while or whatever. They stand up and not do anything for a while, except as you beautiful description, fill yourself. That's exactly what it is, isn't it? Just getting everything set and right. Yeah, okay, all good. Off we go. Yeah, interesting stuff. Okay. Okay, yes.
So you think that time training be very important as people get older, especially with muscles, tibialis anterior.
Yeah, I think it's muscle strength. So we've got a colleague in one of the centers, exercise activity. Really?
Fernando?
Yes.
Exercise activity and rehabilitation.
And really. So Fernando, what's up, Fernando? that's his area. So he works on strength much. And there's, I mean, there are loads of applications of that, and it works, yes. Strength conditioning is very, very important. It's only for athletes or, star athletes. Yeah, and coming back to what John was saying, when you stand up, take your time, etc. So it has got nothing to do with biomechanics. Well, actually, it gives you time to oxygenate your brain. And once you oxygenate your brain, it flows back to your heart, and it puts you in a better disposition to do whatever you want. And especially, I don't know if you read that. You know that there is a higher risk of dying at night when you wake up suddenly you go to the toilet. And you know that the mortality rate is higher when people just do it quickly, rather than wake up, sit down for a couple of minutes, oxygenate your brain, and then you go to the toilet. The risk is lower.
Okay. I think that's really concentrated on lady.
Okay.
I have one
please
question. So I was really interested in what you said about, I think it was your research that said that came up with there wasn't any difference between younger people and older people, and that kind of preparatory cognitive phase of gait initiation. Is that what, did I hear?
Well, there's no significant difference, but we can see some qualitative difference.
Okay, so, but there's a significant statistical difference in your So I was just interested, is that something that's going to be researched? That kind of training people to take more time cognitively to gain initiate, is that a part of?
Yes, I mean, that's the new trend, mindfulness and all this kind of thing, paying attention to things, focusing more on what you do, etc. Yes. Now this is this is an area that has, that is fully researched, so we don't know a lot about it. So people who've been studying biomechanics, they've been studying only biomechanics, but they never combine streams of research as cognition, movement, biomechanics, etc. But now the trend seems to change. So with knowledge exchange, people have got more opportunities to learn from each other and bring streams of research together. But yeah, research in this area is very promising.
It's really important that the work that we do is contextual. All right. It's good to know what's going wrong with the dysphagia. What's structurally going wrong that makes that difficult. It's good to know what's going wrong physiologically or otherwise that makes gait initiation difficult. It's good to know what's going wrong to create the problems of inflammatory bowel disease. But the actual impact of all of that on the individual's life is influenced by everything else in their life around them. And that's the stuff that we also need to get. And you can't get that from measuring anything. That's the stuff you get from talking to people, from talking to the patient, people who take part, but also from talking to, general public like yourselves about, okay, what are the things, what does it matter? What does it mean to you if you have difficulty eating? Well, you're not going to go out socially with your friends. Now, if you're a 20-year-old, that means one thing. If you're a 30-year-old with young family, that means something else. If you're a 50-something, it means something else again, And if you're an older person who's dependent on other people for your care anyway, then it means something else again. Because it's never just one thing. There's always a knock-on of effects. And I'm reminded of a lovely old lady who used to live down the lane from us. She's since died, but she got caught in this cycle of she was terribly frail and very afraid of falling over. She had fallen and she, fractured her pelvis and been in hospital, and then things start to decline, and out she comes again. And because she's afraid of falling, she's then not drinking, and because she's not drinking, she's getting dehydrated. Right? So then she's getting confused. So then she's falling anyway, and then she's ending up back in hospital. And she'd go off to hospital and they'd rehydrate her and get her well again. They'd send her home again. Same thing would happen over and over again. And these are the things, the whole life perspective of it's not just that it's a problem physiologically or mechanically or, biomedically or pharmaceutically or whatever, but that it's a problem for the person in their life, and how it stops or impacts on. Okay, Thanks, Sandy. Good question answering there. I get the lovely job of summing up the day somehow. And I have taken some notes. And first of all, I'd like to really thank my colleagues for their lovely presentations, and Omo in absentia. Honestly, that was like, Omo's presentation was like me in anatomy and physiology classes when I was a trainee nurse going, what? How does that work? But he's reminded me of all of that. So, so that was marvellous. But what did strike me across all of the things that we were talking about, and the comments and discussions that we've had, is the lifestyle influences on all of these things. Yeah, the influences of food and nutrition and smoking and stress and anxiety, activity, either bad because you're not doing enough of it, or needing to do more, or doing too much and that being a problem. And then the environmental contexts. I was interested, Kafui's there on her own now, I was interested, Kafui, in the likelihood that some of the risk of heart disease that we see in older people might be influenced by that sort of post-war austerity in terms of what was available for nutrition, and the really high fat, high energy, high fat foods that were available, and that people, particularly in the poorer social classes, were eating because that was all that they had access to. And of course, over the years, that builds up, so by the time you're 70, 80 or 90, you've got a problem. But I was also thinking about whether the increases in medical science, the advances in medical science, the introduction of statins and things like that also might explain that drop in blood pressure. Yeah. As well as, it'd be interesting to repeat that in 10 years' time, when your 40-year-olds are 50 and your next group of people are, your 30-year-olds are into the 40-year-old, because there's so much more activity in some ways in 20s and 30s than there used to be. All right, and so you might find that mitigates a little bit as well. I'm looking at you. You probably can't see that I am looking at you, but I am. So it struck me that across all of these conditions and all of these things that we've heard about, there are all these lifestyle, if you want to use that word, lifestyle, environmental factors and influences that either help or don't help. Which brings me back to my point that you've got to look at people's situations individually, because what is a benefit for one may not be a benefit for another. But what is very, very clear is that even if we there are things that we can do to mitigate against things like heart disease in older life by healthier lifestyles in our earlier decades and all of that. But there are also some conditions that, if diagnosed in younger age groups, will have a detrimental physiological effect on the body on the way through. But it strikes me from what we've heard today that still keeping as active as you can, that doesn't mean comparing yourself to, I was going to say Paula Radcliffe, but I don't know if any of you know who I mean. Show my age. Comparing yourself to a marathon runner, you haven't got to do that, but keeping just any amount of movement is better than no movement at all, isn't it? And it's about, even through chronic illnesses, whatever we're dealing with, eating as well as we can, moving as well as we are able to, but particularly looking after this as well is so essential to living as well as possible with chronic illnesses throughout life and into older age. And of course, in older age, it's compounded by the natural physiological processes of aging. You do have fewer reserves. I arrived today on, I ride a motorbike, right? So I arrived today on a Kawasaki Z650 that I've had since 1985. And it's the same bike, but honestly, it feels about twice as heavy as it did in 1985, because funnily enough, I'm not 30 anymore. And so it makes a difference, and what we are able to do and what we want to do is different at different stages of life, and you have to allow for that. Yeah, I don't know if that's really where I was going with that thought, but there we go. Anyway, we've had a lovely lot of presentations. Thank you to my colleagues. Wide-ranging work reflecting some of the interests of the Centre for Chronic Illness and Ageing. We've also got really interesting work going on in dementia. I'm hoping that when we do this again, that we can get some of our other colleagues in talking about their work as well. So I think what I'm going to do is draw us to a close so that we can go drink the wine that's waiting for us out there. Not me, because I've got to ride the motorbike home. I want to say thank you to Biddy for making this all work and getting us rooms and sorting all that sort of thing out. But I primarily want to say thank you to Marianne. Marianne's idea to put in for the grant in the first place to enable us to kickstart this off. Marianne, who's done all the hard work, asked me a question occasionally, which I've given an answer to, just a little bit of direction and steer, but it's primarily down to her that we have been able to do this today. So thank you. Thank you, Kafui, for joining us online. Where are you?
I'm still in the UK, actually. I wasn't able to travel, but I had an appointment today, so wasn't able to come into campus.
I know that when we were talking about this, it was sort of a bit touch and go as whether you were going to be here or elsewhere, but you're still in the UK. But thank you for joining us, and we really appreciated your contribution. Okay. Thank you. Okay, so with that, folks, let us draw it to a close and off to the refreshments. So thank you.